السلام عليكم جميعا. صبحكم الله بالخير. معكم روان السند، رئيس قسم الموارد البشرية بمجلس الصحة لدول مجلس التعاون. نرحب بجميع الحضور لبرنامج مكافحة العدوى بعنوان خريطة طريق النمو المهني بالتعاون مع المركز الخليجي لمكافحة العدوى. مشكورين. طبعا نهدف في الاستثمار في الكوادر الخليجية الصحية تحديدا في توحيد جميع طرق مكافحة العدوى، توفير إطار عمل لتطوير وتقييم المهارات والمعرفة بالوقاية من العدوى ومكافحتها وعلم الأوبئة أيضا كذلك. طبعا نتمنى الاستفادة من هذا البرنامج. To be there is a discussion, sharing knowledge between each other. وحنعمل إن شاء الله فيدباك، ناخذ الفيدباك من الاتنديز نهاية السيشن. حنكون معكم بإذن الله. والآن مع الدكتور ماجد to start his session. يعطيكم العافية.
Assalamu alaikum, sabah al-khair, good morning everyone. First of all, I would like to thank this collaboration with the GCC Health Council and giving us the opportunity and to speak with all of you and help and advertise for the GCC Center for Infection Control and AMR. As we know that infection prevention control and antimicrobial resistant, they are the one now, one of the most important, in a hospital setting from program point of view, to prevent a lot of morbidity and mortalities and also decrease the impact and cost. And we know how much infection control being very obvious when we are talking about pandemics and COVID-19. The GCC Center for Infection Prevention Control, AMR, they are very happy to help and cooperate with a lot of organization among GCC and EMRO regions to promote, as my colleague Rawan mentioned, the knowledge and also shared experience or shared experience. My topic, which I will share now, Rabia, tell me if I'm okay, huh? So my topic will be the leadership and developing and an IBC program. So generally speaking, to have an effective infection prevention control program, you need to bring this, program to the attention of higher administration in your hospital. The leadership in your hospital, some people they call it the suite or the C suite in your hospital, where they have the executives and the higher level of administrative and executive level. And to do that, you have to do it in a way you bring their attentions. And to bring their attentions, these people most of the time they are a little bit away from infection control. They may not know the same language that you are talking. The only way to bring their attention is by giving or presenting infection prevention and control as a patient safety program, and to present it as a cost efficient or cost effective program. You have to present it in a way that it will decrease mortality and morbidity, as I said before. You have to present it in a way that this program, it will give you all the standard to benchmark international, hospitals. It's part of the GCC, GCI, or in Saudi Arabia we have our accreditation here with called SIBAHI, and they will come from the government and look for the standard that you are putting in your system to have an effective infection prevention control program. So you have to let them know that. Maybe if you start talking about CLABSI or start talking about the MDROs or other what we know from program inside the infection prevention control, they may not understand what you're talking about. But if you put it in this way, they will come along and they will understand what you're talking about. So when I go over my presentation, you will see how we can present, the program and how we make it effective. So generally speaking, we'll speak about the impact of hospital or health care related infections on patient in hospital. We have to show them that how the impact of this infections, and also the MDRO on patient in the hospital, and we have to present that to them, some improvement project where infection prevention program truly working, and this make them believe, and also we have to let them know that we have cost effectiveness, in our program as infection prevention control, where we save money either by decreased length of stay or decreased consumption of some of major material in the hospital, including antimicrobials. So how we can show them that the healthcare associated infections is a bad thing? We know what health associated infections mean. We mean that whatever infections produce or develop due to direct contact with healthcare setting, and due to mainly contaminated hands or medical devices or environmental services or antimicrobial abuse, and truly linked directly to the staff, they are not following policy and procedures and guidelines if it's already established. And we look to international data. We have to present international data to a higher people, just to understand what people talking about. So this is from England, and you can see here that 300,000 patients per year, they are having hospital-acquired infections, and the death actually among them around 9,000, and it caused, according to the NHS, it's almost 1 billion a year of pounds. So this is a huge impact. In our regions here, if you in the National Guard, actually, this is one of the studies Dr. Balkhi presented or published before. It was done in 2003. Why I want to present this study and the study after and how we are doing it, because point prevalence or period prevalence studies, it's one of the study that our surveys that can present the magnitude of the problem to higher administrations, and sometimes we do it. So here in National Guard, Dr. Balkhi did this in 2003 and published in 2005. I did one in 2017 and published, I think, 2018. And when we present them in a way to benchmark ourselves with international data and show that there are a lot of costs, and this very helpful. So this presentation, when published, or this article when published, actually put the standard that we have a problem. People, they should know that we have a problem. It's clearly that you can see that the blue one or the purple one is the hospital-acquired infection, and the red one, it's community-acquired infections. And you can see that ICU, they have the huge number of hospital-acquired infections. And this will add to our system 12.7-fold increase in hospital length or length of stay from 8 days, which is the average length of stay. So this will add 12.7 folds, like folds, it means like multiplications. So it's a huge impact on the system when it comes to length of stay and cost related with length of stay. So this will just let you know what are the point prevalence and how you can present the burden of healthcare related infections. So the point prevalence versus period prevalence. So the point prevalences mean just we'll take in only one day, and we check our system, all hospitalized patients, according to the standard protocol for doing this kind of studies, and we see all patients captured in that day, having, according to the definitions, hospital-acquired infection, and you can see the hospital-acquired infection definitions there in the CDC. So the protocol is it's very solid, and it's there, in American and also European CDC. The period prevalence has been, we'll take it over days. You can say 3 days. So this is a period prevalence. It can be 7 days or 3 days, 2 days. It will be a period prevalence. Point, just 1 day, one like snapshot. But periods mean over days. So these kind of studies very important if you are just looking to some data in your hospital and trying to present something to your higher administrations. You can do just a snapshot point prevalence kind of study to your patients in the hospital and see how many of them, according to definition, CDC, European or international. Oh, I understand the slide is not there. Is that true? Who's the slide is not there? I'm sorry والله, I didn't notice that. رابعة؟ أخت رابعة.
Yes, دكتور.
السلايد ما هي واضحة, ليتكم كلمتوني.
واضحة, but you need to scroll down عشان تحركها فقط, بس هي موجودة. هي stopped at the first page.
Scroll down, you mean like this? Now it's there? Because somebody is writing there, the slide is not showing.
اوكي, سكرها دكتور وارجع افتحها لو سمحت, لأنها برضو معلقة.
Right. Let me do it again.
No, it's moving now, دكتور.
Shall I go back and do the slideshow? So I'm doing the slideshow. Is it clear? Is it there?
Yes, دكتور.
Okay. Please just let us know if it's not there. يا أخت رابعة والأخوان في البوست جراد, لو تشوفون النوتس اللي موجودة في الشات إذا كان في أحد عنده أي مشاكل. طيب, في الpoint prevalence versus the period prevalence, this is what I'm trying to explain. It's a good tool for you to present hospital-acquired infection to your higher administrations. It's a simple study that you can do and you can present. I will just go to my point prevalence study that I did also here in 2017. And again, this is showing, you know, our hospital-acquired infections and their impact in the hospital. We know that it's pneumonia, the most common hospital-acquired infection, 27.2, then all the others. The problem when we are comparing the hospital-acquired infections versus the device-associated infections, this is all the, you know, the bundles that we are doing. There are a lot of infections, device-not-related infections, like, you know, pneumonia, UTI, bloodstream infection, which is not related to device. We are missing it in the system. We don't see it unless we do point prevalence study. So we need to do it every now and then. And again, this is a tool for you to present your data. From international, data, and this is from USA. They have major 5 hospital-acquired infections: central line-associated infection, ventilator-associated pneumonia, surgical site infection, Clostridium difficile, and catheter-associated urinary tract infections, and these are actually causing 9.8 billion. So putting the problems, the based on your surveillance or point prevalence study, your top priority infections, and then explain it in a course. This is how, higher administrations, executives, CEOs, CMOs, and these people, they understand it like this. If you go deep, they will not understand a lot. How we can present multi-drug resistance. So now we talk about hospital-acquired infections. I told you that whenever you want to present your program and tell people to support you as infection prevention control program, you have to bring the attention of higher administrations, and this is how to do it. You have to do it with data, and this will help you a lot to give you fund, to give you manpower, and also to support you in case if you have any problem in the hospital, they will stand beside you. So that's why infection prevention control in some hospital you find very strong, and in another hospital you find it very weak. Multi-drug resistant organism, also another data that you can present, and we know that antibiotic is very valuable. If you compare, all advances in medicine and to inventing of antibiotic, you will find mortality after inventing antibiotics it's decreased a lot, and comparable to other, it's more than any other technology that we know. So losing antibiotic is a problem. When you put it like this in front of higher administration, they will understand the problem. And we have to let them know that the prevalence is increasing, and it's lead to what we call inadequate therapy. So inadequate therapy, it means that whenever we have a resistant organism and we give them antibiotic that not covering, this will lead to inadequate therapy. And inadequate therapy, it means increase in morbidity, mortality, increased length of stay, and increased cost. So this is a message that we need to give. We can share international, kind of informations and also international, news. How people they are addressing the concern, how they address it in different, platforms. So Tony Blair from one of the ministers or the prime ministers of UK, he presented the prime minister. He presented the AMR action plan. Also, I think either Clinton or Obama, I'm not sure. Also, he presented the action plan. The news, all over the news, you'll find that people they are talking about AMR. So sharing this and putting this initiative to be part of your publications and a community publications, even to everybody, it's very important to bring the importance of MDRO and importance to support infection prevention and control to face this problem. Local studies, just trending of your resistant, pattern. So this is from our colleague Samir Al-Johani, and she presenting, over years from 2004 to 2009 for Acinetobacter and sensitivity or susceptibility to different antibiotic, and you can see that there is a trend of decrease in susceptibility over time. This kind of data, when we present it in higher administrations, they will say, oh, we have a problem. Again, for Pseudomonas aeruginosa, showing the same. Local studies in your regions also may help, like this one in Riyadh, MRSA carriage among children is increasing 23.2. Another one from Western regions were showing that wounds and skin soft tissue infections due to MRSA is going up to 39.5%. So also this also will alert your system and alert looking around, see whatever your colleague in other hospital or in the regions publishing. Also it's important to use it in your agenda. I will just highlight that the how we can present the inadequate therapy. Is it still the same? Still the same يا اخوان رابع. I think it's still the same. The problem people they are not I did it. دقيقة. I'm sorry for that.
Yes, it's perfect now, Doctor.
Perfect. I'm sorry.
Yes.
I have to go back. I summarize everything in the end. I hope I can summarize them quickly. Anyway, so I will just present now the inadequate therapy. What does inadequate therapy, and from international data, how we can present them as a problem in our hospital, and mainly linked to MDROs or multi-drug resistant organism. So inadequate therapy, it means whenever we give antibiotics that not covering, and you can see that hospital-acquired infections due to MDRO are the most common causing of inadequate therapy. We started a patient on antibiotics, later on the culture came with a bug that's resistant to that antibiotic. If you change the antibiotic later on, according to this study, will not decrease the mortality. If you didn't start it early on without any delay, changing the antibiotic later on, it will not do as if you started early. Still, it will not decrease mortality. And here you can easily see that inadequate therapy mainly due to hospital-acquired infections, the blue one and the yellow one, the hospital-acquired infection, for both of them representing hospital-acquired infection. So we can see inadequate therapy mainly due to hospital-acquired infections, and this will lead a lot to mortality and morbidity. Again, multi-drug resistant here, especially Pseudomonas, Staph aureus, Acinetobacter, and others, then Klebsiella pneumoniae, they are the most culprit organism causing hospital-acquired infections and inadequate related therapy and increase in mortality and morbidity according to this study. Here we have different study comparing between a good therapy where we don't have resistant and we started the right treatment early on, which is the yellow one, to the blue one, which is inadequate therapy due to choosing antibiotics that are not covering, and then showing the mortality. So it's clearly here from these different studies, different years, the blue one, which is inadequate therapy related mortality, it's much higher than the yellow one, which is the adequate one. There are a lot of cost effectiveness studies from private hospital, from insurance company, where they can see that they can present the revenue. It will decrease, and having new patients and repetition of the hospital, it will go down if you have a lot of hospital-acquired infection. And this is mainly for the private hospital if they want to present it to as a cost-effective and also a program to advertise for their hospital. So here I'll go quickly over how to build an infection prevention and control effective program. So we have to have educated, competent people, competent staff, and this kind of, I think the GCC Health Council kind of training. This is how we put well-educated, competent, oriented staff. Create multidisciplinary teams. You should build data. It's not only building data, but you have to analyze the data, and you have to put action plan, and then you have to implement it, monitoring all activity and look to all the outcomes. Communications, infection control without communication, either horizontal or vertical, it will not be effective. You have to be very accessible. You have to very presentable in every committees in the hospital, if possible, higher committees, clinical chairman meetings, and also executives meetings. You have to present your agenda and put your thoughts about how to improve processes and make your hospital safe as an environment for patients or for healthcare workers. And we have to be your policies will be all the time up to date. I will share with you one of the things that when we introduced our stewardship program, this was almost in 2015, 2016, and I did this very simple study. I just want to show people that when we started just a process of stewardship program, it's not a full process, smallest process. We managed to decrease, and here is or save around 92,000 riyal in 1 month. So 1 month, 92,000 riyal. And this was actually presented in one of the executive committees, and later on in one of the patient safety forums were praised a lot by the CEO himself, and he supported the program later on. So stewardship program now one of the agenda in every corporate meeting in National Guard. So we have it in quality and patient safety, we have it in the hack, and we have it everywhere. It's just by presenting it's a safe. It's a cost-effective program. It's not only that. When we started the program in that hospital, the red one is the ICU where we put the program in. So the number of MDROs was high. This is the rate 18. And when we established the program, it's not only with the stewardship program. We some also environmental cleaning and disinfection, and also hand hygiene campaign in that ICU. We show that there is decrease in the rate of MDRO in that unit. And another program that we presented in different areas, and I keep presenting every now and then, the C-sections. We have a problem with C-sections. Here is the mean international benchmark, the blue line. And when we started the program here, we can see that we went down to the mean, which is a good kind of achievement. So we have to build the culture of safety. We have to bring everybody around. It's not only infection control. As I said, we have to bring the higher people to support, and also present colleagues from different level, either horizontal or at lower kind of end users or frontliners. And to do that, we should build a culture of safety. Everybody is accountable. Everybody should speak up. We shouldn't, be when it comes to patient safety, having any issues with speaking about what's going on and how to maintain the safety for patients and also the hospital. So in conclusion, international patient safety goal 5. It's real. If you look at it, it's saying clearly from GCI. Clearly saying that it's hospital-acquired infection decrease, showing to the surveillance or the surveyors that you have a program to maintain patient safety by decreasing hospital-acquired infection, and it's mandated by the JCI or the Joint Commission for Accreditations. It will decrease morbidity and mortality, decrease length of stay, improve utilization of bed. It has a lot of steps between education, communication, policy guidance, competency, and also you have to build data, surveillance, focused analysis, and also a lot of teaching and educations. It's cost effective, and I show you some examples how you present your data, either stewardship program or length of stay, stewardship program, and how you save cost of antimicrobial consumption, or you know, decrease length of stay, and this will decrease the cost over the hospital. And it's very important to be presented in your presentations. Infection prevention and control, we find it all the time. People they're saying it's causing problems, it's bringing problem to the system, it's delaying things. But we shouldn't, you know, whenever we have an issue as infection control program, we have to present the problem and we propose the solution. We shouldn't, you know, just say we have a problem with CLABSI and we stop. We have a problem with environmental, you know, issues. We have a problem with MDRO. We should say it, and we should propose, you know, an action plan with a clear, all the element of implementations, from policy and procedure till training and indicators and KPIs to follow. So we have to put it in full. If you keep just saying that I have a problem to higher administrations, then they will feed up from you. So we should present the problem and present the answer, okay, at the same time. With that, I'm concluding. I don't know why they have a problem with the slide. Maybe but I will just conclude with saying that to have an effective infection prevention control, you have to present your program to higher administration and let them buy it in. To let them buy it in, you have to present the data, point privilege study, one of the things that may help you. Also presenting the MDROs and the problem with MDROs from international local data, or from your hospital, as Dr. Samir Al-Jahani did, and also it may help. You have also to do a lot of training to people. If you have a problem, as I said before, you have to present the problem and the answer. And stewardship program, it's easy also program to be presented. If you do it in a small, area in your hospital, show that how much you save from antibiotics. Just bring their cost and say I save this amount of consumption and I save this amount of number of riyal or dinar or whatever. Small programs, improvement projects toward one of your also device related or surgical site infection improvement project, where you show clearly you maintain patient safety by decreasing hospital acquired infection. Also one of the things that you may think of, like the cesarean section data that I present. With that, I would say thank you very much. الأخت روان. Shall we continue, رابع ولا? Hello.
Yes, Doctor, تفضل. Proceed to the second lecture.
So we'll proceed to the second lecture, and then we'll take all the questions. Please just write your questions in the question and answer area, in the chat area, so we can answer them after my second talk. My second talk will be. Are you sure you want to share? My second talk will be about stewardship program and how to build a stewardship program, and very important, how to bring people to stew. I'm sharing now. I'm sharing. 1 minute. Yes. Hey, is it okay now? I think it's okay, huh? Okay. Yes. So I will go now my second talk. to antimicrobial stewardship program, and here actually antimicrobial stewardship program now it's become one of the important program with the infection prevention and control, other surveillance that they are doing in the hospital. It can be under infection prevention and control. It can be under ID services, infectious disease services, or also it can be under clinical pharmacy, an ID clinical pharmacy. We have well developed clinical pharmacy program with ID section. It's not where this program or who is the main player or leader of this program. The most important thing, this program need to be alive and need to be presented, as I said before, to everybody in the hospital. So we need to understand the basic concept of antimicrobial stewardship program implementations, and then I will just also review with you how we did it and how we published some of the data. And it's these program materials. It's available in National Guard. If somebody would like to have a look, I can share it later on. So how we understand the basic concept of implementation of stewardship program. Implementation, it means that the first thing, as I said before in my previous presentation, you have to bring this program up to your C-suite and higher administration, executive people, so they believe in it. They give you the manpower and they give you the budget and training and whatever you need. The other thing, you have to build a team. Build team and allies. We cannot run infection prevention control without different people in the hospital, and I will speak about important main players, including ID services and infectious disease infection control, and nursing and quality and patient safety. So and pharmacies, they need all of these people work together, and also ISID. So all of them, they need to work together. Very important to have clear policy and you have a clear indicator to present your system, and education. So it's all about education. It's very bad when you put a program and indicators and you put some materials for let's say now part of the stewardship program, surgical prophylaxis policy, and then we not let people know about surgical prophylaxis policy, part of the stewardship program. I have to educate our colleague in surgery or operation services about what the policy is saying and how we choose the right antibiotic with the right situation, with the right dose all the time. So it's a continuous educations for stewardship program. It's not only one time or once per year kind of education, it's a continuous educations and competencies. And this all will help implementations. As I said before, and this is how I do it all the time, when I ever presenting my problems, like I need stewardship program in my hospital, I should present it in a way that it's a public health concern. Now, antimicrobial resistant is not like it's a small issues in your hospital. It's a public health concern, same as COVID-19 problem, same as Ebola, same as any other major public health concern issues. It's touch a lot patient safety, and I already presented that before. We know that we have a lot of limitation when it comes to developing a new antimicrobials. So we have over time the number of new antibiotics decreasing, and not only that, the start of the arrow, actually that the new antibiotic developed or discovered, the end of the arrow here, it means resistant already started or being documented. So you can see that whenever we have a new antibiotics over a period of time between 5 years or few years till 10 years max, most of antibiotics they will start or bacteria start causing some resistance or develop some resistance to these antibiotics. So not only that we have a problem with the new antibiotics, but also we have a problem that antibiotics, they fade away with time due to resistance. And those also need to be discussed thoroughly, and we look to our resources all the time and update our formulary to have antibiotic with different options to cover different infections. 20 to 50% of all prescribed antibiotic is due to there is no unnecessary or inappropriate kind of antibiotic. Due to there is no need for it at all. It's due to wrong choice of antibiotic. Due to patients there is no longer need of antibiotic, so we start antibiotic for a few days. Patients improve, we should stop, but people they continue for longer period. It could be wrong dose. It could be very broad spectrum for very susceptible bacteria. So all of these, it means inappropriate antibiotics. 20 to 50% in our system of prescribed antibiotics due to inappropriate kind of reasons. It's not only that, we know from literatures clearly that whenever we give carbapenem, enterobacteriaceae will have 15-fold chance to develop resistance to our CRE. If we have E. coli and you start cephalosporin, 5.8-fold chance increase to have ASBL. So giving antibiotic, it has a collateral damages. It will not just treat the patient, but will have a problem later on resistance. And this not only on patients, not only in individual. Actually, it go to causing problem to the hospital. So we have increased prevalence of MDROs in your hospital. It's not only on the patient's colonization or infection, but also to the hospital. And it's not only to the hospital, to your area and other hospital you're sharing patients with or staff, and it could be new regions. So the impact it's expanded. It's not only on the patients, it go to the hospital, it go to the region later on. And when we are talking about stewardship program, it doesn't mean that we'll stop antibiotic or restrict antibiotic. Actually, when we're talking about stewardship program, we're saying that to optimize using of the antibiotic. So we should optimize using the right agent, the right dose, the right route, and the right duration. And this will minimize, and this is why we want this program, minimize bad consequences like resistant or antibiotic-related toxicity, including renal failure or decrease the cost. So this is mainly the goal. The goal is to decrease emergence of resistance, improve outcome, and control the cost. So ASB will do all the job if you look into this. So antimicrobial stewardship program, if you are looking how to do the goals, all the goals, this is how we do it. This will decrease, as I said, toxicity, decrease selection of resistance, also decrease of emergence of virulent organism like C. diff. And if you combine stewardship program with infection prevention and control, policy and procedures and implementations, maintaining these like hand washing and environmental, cleaning and disinfection, this for sure will decrease emergence and transmissions or prevalence of resistant organisms in your hospital. Stewardship program should be combined all the time with good infection prevention control program, and in the end will reduce the healthcare cost and also all impact on care. As I said before, the program can be under any body in your hospital, like clinical pharmacy and pharmacy, or infection control and infectious diseases, but we have to define it. We have to give it a single leader. Let's say now in National Guards and infection prevention control, so it will be under infection prevention control, and they are responsible to bring people to help and implement the program and to show that it's effective and present it all the time. As I said, we present it everywhere in the higher committees, so they understand that we are accountable and we are trying to move on with our agenda. And it's not one-day program, it's not one-time program. So it's like expanding, improving. So when we start in one area, then we went to another area, then we do some improving in ISID, then we did some training on prophylaxis. Now we're looking to have some apps to help in so it's a continuous kind of process. It's not just one day, it's a continuous process. So good to have somebody in charge and accountable to move on with the program. A lot of people they are playing the core team, as I said before, infectious diseases and the clinical pharmacy, especially those with infectious disease training. But we have a lot of supported team like infection control, quality assurance, information and technology, the ISID, the hospital epidemiologist, the microbiology, and a lot of people in the hospital. So we have nurses with us working in the stewardship program. We have ICU doctor working with us, oncology doctor working with us, champions everywhere in the hospital, infection control link program people. So we have different, collaborative team to move with this agenda. We can depend all the time on nurses. I will just share with you two studies. This study, they put one of the nurses and they educate them about the right antibiotic choices based on guideline, and truly that show that nursing, they are playing a major role and maintain going with the program in that clinical area just by education. So they educate the nurses about the stewardship program and the reason of antibiotics, the appropriate antibiotics, and they carry on the program in there. So we have to, the role of nursing in the stewardship program become very strong, and having a lot of nurses and train them, that's very important. Another also study showing that almost the same, where we have leaders among nurses and infection prevention and control, practitioners. This will help a lot, the program. It's not only the physicians, not only the pharmacists, but having people to lead it at their area, at the clinical unit, also is very helpful. And nursing will be a good resource for you to train, let them monitor in their clinical area, in the unit, like ICU or ward, or in the surgical or operations like holding pain, OR. So we'll monitor all surgical procedures. We have to train them and educate them and link them. So they will be very helpful. Having policy and procedures, this is excellent and we should have it, but this will not change the practice. You have to have interventions, and now I'll give you some interventions. What are the interventions that you need to do to have an effective stewardship program? So policies, guidelines, protocols, training, all of these are excellent, but still you have to do some interventions. So we have something called prospective audit. We have something called formulary restrictions and reauthorizations, antibiotic time out, and de-escalation approach. So all of these considered to be interventions. So prospective audit and feedback, we run it here in National Guard in ICUs. So we have people, a team, visit the ICU, sit with them, review all the patients as prospectively way to see if their antibiotic appropriate or not. And this is very excellent, and this is the most far important intervention, to have a team, physicians, pharmacists with one infection prevention control and one nurse, visit the area twice, 3 times a week, sit with them, review all the patients in that area, especially the one on antibiotics. Sometimes we target specific antibiotic like carbapenem, and give them the feedback. Though that is the time-consuming labor, sometimes we don't have manpower, but as I said, this is the most important, really kind of interventions that we need to think of, especially in the area with high consumption of antimicrobial like ICUs or intensive care units and oncology and hematology transplant units. The other interventions, which is one of the things that it's easy to be done, which is the formulary restrictions and reauthorization. So we said that to the system, your hospital, if it's electronic, this antibiotic, nobody can give it except ID need to approve it. And it's very effective. In this hospital, actually, they show when they stop and restrict the ciprofloxacin, which is one of the quinolones, the C. diff rate going down. So it's very effective interventions. It's called formulary restrictions and reauthorizations. It can be for all antibiotics if you have enough manpower, or can be for specific antibiotics in your system, especially the one with collateral damage like ciprofloxacin, cephalosporin, and carbapenems. Pharmacy-driven interventions, which is one of the de-escalation process. In the system, you have clear policy to change antibiotic. Let's say change from meropenem to imipenem, or change from meropenem to piperacillin. So, and the pharmacist will do it. There's no need for physicians to go there and change it. whenever they see that antibiotic with the specific indication, they can automatically, change it. They can automatically stop antibiotic. They can automatically optimize the dose and check, the level of antibiotics in the blood. They can stop them in case if there is no need for it. So having this as a de-escalation approach, also another intervention that you need to think of. Antibiotic time out, this is during the round. Let's say now we are doing round in the ICU. We need to implement in there, one of the nurses there just to ask the team before going from patient to patients, this patient on this antibiotic, do we need to continue or not? Just like time out. Just we ask, do we need to continue in this antibiotic or no need to continue in this antibiotic? Do you need to change it? Do you need to adjust the doses? So just to remind them, at the end of the round, let's say on one patient, and they review the medication, they have to have somebody there to remind them about the antibiotic and the needs of continuing the antibiotic or changing. It's very effective. We established it in one of our PICU, pediatric ICU, and it's published also as a study from our colleague in pediatric side. De-escalation approach, it's the way that you can manage or balance the problem with having very sick patient where you want to start broad-spectrum antibiotic and the emergence of of resistant bug. And how to do it? We tell people it's okay, especially the ICU doctors, because all the time they're saying we have sick people, you shouldn't restrict broad-spectrum antibiotic. I said okay, whenever you have sick patients, start whatever antibiotic you want. I don't have a problem. But before starting the antibiotics, you have to take all the cultures. At third day of admissions, you have to review the patient, review the cultures, and according to the culture, patient improvement, you have to go down with antibiotics or change antibiotics, stop antibiotic infection. So this is the de-escalation approach. It will balance between having sick patients and not compromising, the emergence or the pressure of antibiotic and emerging resistant bacteria. It's an excellent approach that we need to think about in the ICU. So based on what I said from interventions, we will say that we have something called front-end strategy or back-end strategy. Front-end strategies mean that the interventions will be just asking that you have restrictions, reauthorization, so nobody can start antibiotic without your permission. This is called front-end strategy, and most of the time you will have a lot of difficulty to convince the hospital because doctors, they want to start whatever they want. The other way around is the back-end strategy, where you have to do prospective audit and feedback, do the escalation approach and time out, and also pharmacy-driven intervention. So this is all back-end. So we'll let them start, but then we'll control. So this is the two approaches in general. I give you in details about the intervention that you need to think of, and also the how you classify them, either it's front end or back end. Very important to have your data, as I said before, and reporting this data and look at them, share it with your colleague to understand the problems all the time. Sorry, I went to the other side. Education is another thing. In one study, actually, what they did just continuous long-term, kind of educations, and they show that after stopping the education for a while, people behaviors change and they continue having the same improvement even after they stop the education. They continue education for a while, but then they stop. But people, their knowledge and awareness increased in a point that they continue this, approach without education. I will go quickly here that how we did. We did a lot of, initiatives and interventions. In the end, we have successful, alhamdulillah, starting, still not mature enough, but we have it as a program. And policy and procedures, very important, as I said, clear indicators, so the outcome measures and also processes measures. So on our program here, we did the daily, the DDD, which is the daily dose of an antibiotic and duration of therapy, and the length of stay also we considered part of the outcome, rate of MDRO, Clostridium difficile rate, and antimicrobial cost. All of this our outcome measures. And for processes, appropriateness of the antimicrobial, rate of acceptance, rate of IV to BO switch. All of these are processes measures in our program. As I said, we formulate committees. We have all the stakeholders with us ICU nurses, oncology. We have a lot of people working with us, and this is very active, committee. And a lot of educational activities, either classes and videos on the internet and e-learning, yearly antibiotic awareness and educational curriculum. It's ongoing, and people, they do this, continuously. We have like set of slides that we keep presenting to different target group in the hospital. So we give the oncology different than, surgical, different than medical, different than ER, like educational kind of slides. As I said, very important to have your data. I'm presenting most of our data due to our problem in our hospital here is due to inappropriate choice of antibiotic. People, they tend to give the broad spectrum antibiotic, meropenem and imipenem, more than others. And we noticed whenever we started the prospective audit and feedback, people behaviors change. It's not only that the antibiotic, we cut the antibiotic, but actually they establish their, way to not counseling or consulting, infection prevention and control, and also they change their behavior of how to deal with patients. So it's good because we're sitting with people. It's intervention, but also it's educational at the same time. Surgical prophylaxis improved, and policy and procedures will help a lot, as I said before, and not only for the stewardship, but also for, like, we have policy for cholesterol dosing, policy for, imipenem, meropenem, when to start this and how to switch among them, and we show, as I said, that we saved a lot of money, and we keep showing to everybody in the hospital to understand the program is effective and is ongoing. Another policy that we have changing between caspofungin and durafungin, mainly it's a cost effective because this will decrease the cost in the hospital, and caspofungin almost like triple the cost of endurafungin. So this kind of also program looking to cost mainly, it's very important. Using the ISID and electronic, system for restrictions, and try to improve it over the time, digitalize some of your activities, and if you have electronic patients file, this will help a lot. I think with that, I will just ignore this. This is my conclusion. So to have a successful social program is a teamwork. You have to have a lot of people working with you, ID, infection control, clinical pharmacists, microbiology, and a lot of people, working with you. You have to start with the slow, what we call low-hanging fruit. So one unit, start few program. You can start by prospective audit and feedback, or some other interventions, and then educations, and you have to establish your KPIs and follow and present their KPIs to everybody. And we have to tell people that stewardship program, though that will control antibiotic, optimize using of antibiotic, but it's safe and effective. It will not cause, issues, and what will not deny patients from, appropriate antibiotic, as long we structure it in a good program. With that ending, I'll say thank you very much, and I think now we will have a break and discussion. So I'll look to the published one, صح? I think I'll look to the published one. So one of the colleague asking here, good morning, in your opinion, how can infection preventions convince the leaders about the importance of integrating them in the electronic medical file by easy accessing of the file, by implementation program, software, and health preference AMR? So this is what I was talking about all the time, actually. I'm trying to present how to bring the leadership to your, how to bring your agenda to the leadership, how to let them support you. And to let them support you, it's not only going there with problems. You have to go there with answers. Go there with data that you build a small program, easy. Maybe it's that program started by you only in one unit, where we show that people, they are actually maintain safety of patient by decreasing antibiotic or length of stay. Small program, or improvement project, and then go up and present it. Show them that this is what we did, and we did it small because we need support, and the support I need this and this and that. Okay, and show them the costs, show them how much they save. One of the studies, I didn't share it here with us. It's one of the ICU, I think it was in the United States. One of the ICU were actually looking for more manpower to run a stewardship program in their ICU. The hospital refused. So what they did a study. They asked for a grant. The grant of that study, the money coming for that study, what they did, actually they hire one nurse. That nurse ran the program in the ICU for 1 year. So during that year, they actually able to present, because it's a study, that nurse with that grant cost, which is, I don't know how much, but it's cost much less from the intervention they did. So they save a lot of antibiotic and they save a lot of length of stay in that ICU. And it will come to cost, they saved a lot. So they present this study to higher administration. They show that hiring the nurse costs, let's say 1,000 riyal, but during this year we saved 100,000 riyal. And we need this 100,000 riyal to hire more people. And actually they convince the higher administration, and they give them the money, and they hire more people, and they run the program. So this is the way. You have to bring it clear, and they have to bring it ready, and you have to bring it mature with data to your higher administration. Then they will convince, and they will work with you. If you have a mandate from your hospital or from the region, some like here in Saudi Arabia, they have the Sibahi, which is the accreditation. They mandate to have a good stewardship program. So also this mandate will help sometime. Okay, sit with second. Another questions about, we know what is going with MDRO and antibiotic resistance worldwide. Some of countries have done create work to decrease AMR, while others just celebrating the event of November every year. Misuse of antibiotic replace probiotics. Okay, so he's saying that, yeah, there are two ways of approaching things, and this is also I try to highlight it later on. Whenever you invest in something, you have to sustain your investment. It's not just, one time, 1 day celebration, 1 week. It's not like this. You have to maintain your program by expanding, by putting more, training, by more indicators, and you have to continue. It's not only 1 day or just November, time of stewardship or antimicrobial awareness week, and then we stop. It's a continuous process, and you have to support it all the time. Another one, is there a protocol? Another question is there a protocol in place to de-escalate or change the antibiotic by the clinical pharmacist based on the culture sensitivity? So we cannot, just concentrate on culture and sensitivity. You have to put the clinical data in it. So you cannot say for a clinical pharmacy, they can go in and just change antibiotic based on culture and sensitivity. It can't be like this. But clinical pharmacy can bring this to one of the ID, which is covering stewardship program, and he will help to give the decisions. But what we can do, we can change. Let's say, as I mentioned before, switching, policies, automatic switching policies, especially with comparative, antimicrobials like antifungal from andulafungin to caspofungin, or meropenem to mepenem, or mepenem to meropenem, stopping antibiotic if there is no reordering and other thing. But changing just based on culture and sensitivity, we cannot do it. We have to put some clinical element in it, patient improvement, site of infection. Let's say now I have a bug that's sensitive to tigecycline. Okay, tigecycline, but tigecycline will not go to the brain. So I have something that go to the brain, and the problem, the patient has meningitis. So I cannot just say, okay, sensitive to tigecycline, give tigecycline, but I have to have a right penetrations, a right indications, you know, from international data that this antibiotic is good for that infection. So you have a clinical you know, background that it's not only based on cultural sensitivity. How can we implement antibiotic stewardship in a hospital which do not have microbiology lab? I think still you can do that by reviewing your antibiotic. There is stewardship program in outpatient setting. There is a program called stewardship program in outpatient setting. So let's say in an area or a polyclinic where you don't have microbiology lab, still you have to element of stewardship program. Still you can يعني, put it there and keep it there. Monitor your antibiotic given for upper respiratory tract infection, and restricting antibiotic for given for pneumonia to 5 days for outpatients. So you have still other elements that you can have and you can implement, but still you need to monitor. You need to monitor. You need to put policy and procedure, almost same what I said before, but it will be for you know, very small scale. Now I will go to next questions. How can we implement antibiotics in the hospital? Oh, this is the same question again. All the study presented were at hospital tertiary setting. That about primary healthcare setting. This also I already mentioned that. Stewardship program, it can be in any clinical setting with different elements. You have a stewardship program in oncology setting. You have a stewardship program in ICU settings, which is the main important, you know, ICU and oncology. You have antifungal or fungal or antifungal stewardship program. You have stewardship program in outpatient setting. You have special stewardship program in a pharmacy, you know, inside the pharmacy. So you have it in different area. I just present what I have, like in still you have it in different setting, and you have almost the same approach, but in different setting. So somebody said, don't you think that AMR stewardship should be discussed in a national level, then regional, then into hospital? I think this kind of program needs to huge resources and manpower. No, I don't think so. I think everybody of us, everyone, if we just be carefully looking to what, you know, antibiotic need to prescribe, this will add a lot to stewardship program. And when it comes to national, international level, they have more than just the hospital setting intervention. They are looking to what we call One Health approach. They're looking for antibiotic and antimicrobial in agricultures and in animals and environment, and they are looking to the sewage system, and they have different, you know, kind of setting where to implement, you know, AMR national action plan. The AMR national action plan is different than hospital setting, and I think maybe small hospital they can have it. Outpatient setting, you know, clinical care, still they have some elements. We need to start at some point. It's the program to make it complete at the national level. You need initiatives from every setting and from every ministry. So in one of the ministries that we have, one of the committees we have in under the CDC, so the CDC, we have different people at the national level. It's something else. We have different from different areas, from school health, from immunization committee, because still all of them is under stewardship program. And it's not stewardship program and under antimicrobial resistant action plan of the country, which is a different setting. And this is what we need to think of when it comes to very higher level. Thanks for interesting presentation. Since the slides not moving well, I'm sorry about that. Could you please summarize the? I think I did, but this is summarize the first lecture, all of it. I will try. I will try. So generally speaking, the first lecture was talking about how to convince the leadership and how to present the infection prevention control program to your leadership. You have to present in a patient safety module, cost effectiveness module. You have to use data to present, and you present interventions also, and how you save this data, or how you maintain patient safety. Point previous study, one of the things, presenting the MDRO issues from local studies, from data, from international initiatives. Also, that's one of the things you need to present. Very important to have an effective infection prevention control program, to have well-educated, competent people, and you have good communications. You have all the 8 elements that I mentioned before regarding having an effective program. You have to show them that the program is effective from cost point of view. It will save money, and you have to show it in numbers. It's not only that I have a program that it will decrease the cost or length of stay and maintain patient safety. No, you have to show it in numbers. And we decrease this amount of hospital-acquired infection. We decrease this amount of money, even if it's small, even if it's fraction, if it's for 1 unit. But when you present it to them, you present it in that way for leadership, so they can take it. Sometimes maybe the leadership, some hospital, they have non-clinicians leaders. So you have to present in a patient safety kind of program. You have to present in a cost effectiveness program. I did already some examples for another question from Ahmed regarding KPIs for stewardship program. I present what we use here in my hospital. So we put them into 2 categories. One of them is the outcome, what we need as an outcome. So I put in the outcome, I want to decrease antimicrobial consumptions, and I put them into KPIs. Antimicrobial consumption, we present them in decrease of daily defined dose, DDDs, and daily or duration of therapy, DOTs. And also we need to present that we decrease the MDRO rate, and also we need to present decrease of C. diff or C. difficile infection. So these 3 considered to be outcome. For processes, we have to look to appropriateness of antimicrobial. We have to look to number of compliance to recommendations and other thing. You can choose differently, but this is what we choose in our program. I want to ask, Min Wafa, I want to ask if this program applied for post-cardiac surgery patients, because for ICU doctor mainly concerned infection post-cardiac surgery, which could be lead very bad outcome. Like you can do it everywhere, even post-cardiac surgery. You can do a stewardship program, but if you are looking to surgical site infection, stewardship program, it will not decrease only. It will not work alone. You have, and I mentioned that already. Stewardship program, it will work if you combine it with good infection prevention control program. So you have to have the whole bundle of surgical site infection bundle for prevention. If it's cabbage, you have to maintain all the cabbage elements and bundles of cabbage, and it's not only stewardship program. Stewardship program will add, but you have to have a good infection prevention control program, especially if it's something related to bundle of care. For cardiac surgery, either surgical site infection or central line related infection or cabbage. So there is a bundle of care that you need to follow. Okay, not only the ASP. ASP will add a lot, but all together. Dr. Iman, I would like to ask about antibiotic therapy in mild and in intermediate COVID-19. This is a little bit away, but generally speaking, the WHO recommended to categorize COVID-19 infection into 3 groups. Mild infections, no need to give antibiotic. Moderate infection, you need to consider antibiotic based on clinical decision. And severe, infections where you have severe, pneumonia, and then you have to cover with community, community-acquired infection. If patient just came from outside, community-acquired infection, selection for antibiotic. I will not give names, but generally speaking, this is the 3 categories where WHO categorize antibiotic therapy for COVID-19. So mild infection, no antibiotics at all. No anything, just supportive therapy. Moderate infection, where you no need for antibiotic, but clinicians, they may add something, and it's open for them. And severe infection, you need to put some empirical antibiotic coverage to community-acquired infection. So it will be very simple, antibiotic, especially if the patient coming from outside the hospital. In Yemen, we don't have a precise document in inappropriate use of antibiotics. On your opinion, how can start to determine the problem inside our hospital? The issue, if you don't have it, you have two things. Either to start having it, so you have to have a system where you can measure the consumption of antibiotic in your hospital, or start somewhere else. Okay, I don't have a measure for antibiotic consumption, but still I can produce a guideline for our hospital to determine the right choices of available antibiotic in my hospital, and the duration of therapy. This is alone, it's one of the elements of stewardship program. Put a guideline for antibiotic choices, antimicrobial guideline that's customized to your hospital, the choices of antibiotic that you have, the type of infection that you see in your hospital, and just determine the duration, cut the duration. This is alone, it's one element. So if you don't have the full, supports the antibiotic consumptions and other thing, you can start by this. But I will advise you, if you start by in one area, small, kind of approach, you need to think how to move on and how to establish antibiotic consumption rate or utilization rate in your hospital. There is electronic way and there is a form way, and actually we are here in GCC Center for Infection Prevention and Control. We are about to produce a tool. Inshallah soon we'll publish it. The tool actually help people to document it manually, so it will be manual. If you have somebody, will train them on to use that tool in one unit. You cannot do it all over the hospital, but at least in one unit you can measure the antibiotic consumption in that unit. Then whenever you have interventions, you can compare before and after intervention your consumption. But generally speaking, don't let this stop you. Start somewhere else. Start with low-hanging fruit in your area, where the things that you can improve quickly, and then inshallah later on you can go higher and higher. Do you think medical practitioners, especially physicians, need program regarding the proper use of utilization antibiotics, especially the restricted antibiotic, in order to avoid resistance or complication in the future to the patient? Do you think medical practitioner, especially physician, need program regarding the proper use of it? They need education, so they know the common infection that they will see in their practices, what kind of antibiotic you need to start in two conditions, in a hospital acquired setting or community acquired setting. They need also some guidance. So some hospital, I know that they are actually publishing an app, and there is one actually. CDC, they have an app. CDC, they have an app. You can give it to physicians, CDC, an approved app, where they can guide them through what are the appropriate antibiotics that they need to choose in different settings. You can find it in CDC. It's an app there, and it's very helpful. Maybe they have different antibiotics than what you use in your hospital, but at least this is the start. Some hospitals actually, they customize these apps to their needs, to know what type of infection they have and what antibiotics they have in their system. So they just mention in their apps the right antibiotic, or even paperwork, like PDF file that you have it in, and produce it and email it to everybody with simple common infection that you have in your area, and what are the right antibiotic, right duration of antibiotic, or right doses, and adjustment in case if you have renal or liver failure. How can document our attendance? It will be in the end, I think. And there is a link you have to send at the end. Excellent informative lecture. Thank you very much, Doctor. Can we have idea about the relation between antibiotic abuse and superinfection in COVID-19? Of course, get more antibiotic, and I presented that already. We'll have more resistant bug. and in a hospital setting, it will increase, as I said, the carbapenem 15-fold for carbapenem resistant urobacteriaceae, and for cephalosporin use, it will increase and increase around 5.6 folds for resistant organisms. So there is collateral damage that very obvious. I think with that I end. We'll give few minutes. I think maybe few minutes just to relax. 5 minutes. 5 minutes, and then we'll start the next talk after 5 minutes from now. Thank you very much. Thank you all. So Basim, prepare your slides, huh? You can prepare your slides. So after 5 minutes we start, inshallah. Yes.
Dr. Majid. Dr. Majid.
يس السلام عليكم مرة ثانية. هشام احتجت بعد المايك شوية. هشام بعد المايك شوية عشان صوت الهواء كذا قوي. طيب yes كذا much better. We have a little change in our schedule, so we just change the lecture for Basim. It will be we'll just change the order. So Mr. Hisham Eid, he's an infection control coordinator here in Infection Prevention Control Program Riyadh, King Abdulaziz Medical City. He will present first, and then we'll go with the schedule the same. So it will be his talk for like 30 minutes, and it will be about identification of infectious disease processes. Mr. Hisham, you can go ahead.
Okay, Dr. Majid, thank you. I will present, as Dr. Majid mentioned, identification of infectious disease process. So our outline will be, we need to speak about the chain of infection, then the natural of microorganism, and then we need to specify about bacteria, fungi and viruses, parasite, embryons, and then we need to speak about some diagnostic method which diagnose the infection. So let's start by basic things, the chain of infection. If anybody have infection, you need to have, first thing, you need to have infectious agent. Agent, this microorganism could be bacteria, viruses, fungi, protozoa, parasite, any agent. Then that microorganism, they like to grow and to go to from person to person or from even person to equipment, so that they need place to live in. So the place is called the reservoir. Could be people, could be equipment, or even water. Then they go from port of exit to another, as I mentioned, to another victim or another equipment. So they need the source or port of exit. They need a place or how go through it. So they can go by excretion or even secretion or droplet, depend on microorganism and depend on the important things here, the mode of transmission. If I will say patient have MRSA, and that MRSA, as all of us knows, that one it's the mode of transmission is by contact way, so that it will be by contact way from first one to the second one. So mode of transmission is very important here. Depending on microorganism, as I mentioned, we have 3 mode of transmission: contact or droplet or airborne. And then they need to go to another victim, which they have a portal of entry. The portal of entry, it could be the same like a portal of exit by respiratory, by gastrointestinal system, by genitourinary system, by mucous membrane. So this is the port of entry. Then they need to have a new victim, which is that one is called susceptible host, which is high risk to have an infection, like a cancer patient, elderly patient, burn patient, surgical patient, diabetic patient. As all these group, it's high risk, so it's easy to have infection. So let's start by what we mean by microorganism. Microorganism, it is a small number of microorganism called pathogen. Microorganism could be normally or could be pathogen. Pathogen, which is cause disease, and most of harmless called commensals, which is sometimes you can find it even in the skin. And I would like to give an example here for Escherichia coli. Escherichia coli, you can find it as a normally in the intestine, and this is beneficial for us to break down the waste, and it's also to synthesis of vitamin K, which is help to control the bleeding. That one is the benefit for E. coli, which now working as a friend for us. When become an enemy and pathogen, it will have a problem. Certain various could be have diarrhea for us. If it moves to another part of the body, could happen UTI and sepsis and etc. So it's very important to know these things. We have a lot of factors affecting the growth of microorganism. As all you know, the microorganism depend on microorganism. Some of them they live in high temperature, some of them in low temperature. Even the pH, the acidity versus alkalosis, the food, the moisture, the oxygen, so that some of them they need an oxygen to live in, some without oxygen. So it's very even important also to classify the microorganism. Some who live in the presence of oxygen, it's called aerobic microorganism. Some who live without oxygen, it's called anaerobic organism. Some will grow with or without oxygen, it's called facultative organism. So it's very important for us to know these things. Then type of microbes or microorganism, you can divide it in 2 major types, which is cellular and acellular. Cellular in bacteria and fungal and protozoa, you will have in bacteria who will have the cell wall. In fungi and protozoa, you can even see the cell membrane. In viruses, we don't have the cell membrane or even the cell wall, but called acellular. So also another classification depends on the size of microbes. As all know that the viruses is very the smallest regarding to the bacteria or hem length. For hem length, it could be 10 multiplied minus 3. And so microbes size range from 10 nanometers to 200 micrometers. فديبند on the classification.
يعني على اساس مشكله سووا الحركه، انا ماني It's extra precautions يدور السواب هذه لكن ماني into with a lot الصراحة.
Dr. Majid, can you mute your mic, please?
Oh, sorry.
So let's start by bacteria. Bacteria, we need to divide bacteria to gram-positive and gram-negative, as this is the gram stain. This is the basic element or the basic step to classify bacteria. So gram-positive organism, high-thick peptidoglycan wall does not allow the crystal violet dye to be removed during alcohol wash. All the microlab knows about these things. And the gram-negative, this one, contain a liposaccharide layer in which allow the crystal violet to be rinsed during the alcohol. Then, as all of you know, the gram-positive to become like a violet in color, and the gram-negative it will be in red in color. This is just to classify gram-positive to gram-negative. So if you need to classify microorganism according to the present or the require an oxygen, so aerobic we have a gram-positive. So we have cocci and bacilli, and even for cocci we already classified to staph and strepto. And even the staph we have catalase positive, and we have even coagulase positive and coagulase negative. They have a lot of even if you go to the cocci, staphylococcus, then catalase positive, then coagulase positive, coagulase negative. Then from coagulase positive, also we have MRSA and MSSA. We have the methicillin resistant Staph aureus or methicillin sensitive Staph aureus. So it depends on the classification. Then the same things here for cocci and same things for bacilli. I don't like to go deep for these lectures because already I just have I have half an hour. Let's go to the aerobic. We have the same for gram-negative cocci, bacilli, or coccobacilli. Cocci, an example for like a Debilococci, which is Neisseria, and Coccobacilli, a lot of example. The most famous one, Acinetobacter. Bacilli, like we have an E. coli, Klebsiella, Proteus, all these microorganisms gram-negative. Pseudomonas, Salmonella, Shigella, and Vibro, like, and we need to know by even the shape, it look like curved shaped. So some microorganism is the Debilococci, some cocci in chains, depend, and some in bacilli. Depend on the shape, the microbiology team, they can diagnose and they can know what type of microorganism. If we go to anaerobic, the same things. We have a gram-positive and a gram-negative. A gram-positive, the most, the one could be Clostridium, the most, famous one. The gram-negative also could an example like bacteroids. So we have a spore-forming bacteria like a C. diff. It is also here one example of positive. And then if you need to go to the second element, we finish the bacteria. We go to fungi. Fungi, it's a huge family. We have yeast models and dimorphic. An example for yeast, we have a Candida and a Crypto, and also we have Aspergillus, and the most common organism like to contaminated in urine, it will be Candida, because you can find it even in the skin. So number 3, we'll go to the viruses. It's very small, as I mentioned, and consists of RNA and DNA core and an outer coat of protein. They can reproduce and they grow only inside the living cell. This is the important things. They can live, some depend on the microorganism outside, but they lie, and then they died, but they need to grow only inside the living cells. And if you everyone speaking about the hot topics now, the coronaviruses are large family of viruses that cause a wide range of illness, from a normal common cold and to severe disease and severe pneumonia. An example for that could MERS-CoV, Middle East respiratory symptoms, or severe acute respiratory syndrome, which is SARS. And COVID-19 now, it is a strain that has not been previously identified in human and could be also zoonotic. It means they are transmitted between animals and people. Like a SARS, we know there is bat, then the cats send it to a human body, and same things for MERS, send it by camel, and camel then to the human. And until now, we don't found the COVID. What's the microorganism they have? The coronaviruses, as I mentioned, it's a big family. By the way, the name of coronaviruses is derived from Latin word. It's called corona, meaning a crown or halo. So, as I mentioned here, we have a lot of many types of human coronaviruses. Human coronaviruses, common cold, as all of us know these numbers. Human corona 229E, OC43, and even an LH63 or human corona U1. For these the four types, which is normal, and you can find it in normal flu, and the others, which is SARS or MERS-CoV, or even SARS-2, which is COVID-19. Let's speak about parasite. Parasite, we have protozoa, and an example of that, like malaria, and metazoa, and we have a lot of things here under protozoa. Prions are infectious agents that do not have any genes. The problem, we don't have genes, and consist of protein which replicate in the animal or human brain, and they need a long incubation period. This prions disease, which is already sporadically 85 to 95%, and that one, it is high resistant to routine sterilization. Even with some, our colleague who will speak about clinical disinfectant will highlight about the prion disease, and it will cause a serious illness, which is called Crestfalled Jacob disease, or Junun al-Baqar, cow mat. For this one is mainly the age between 50 to 70 years of age, and they have a lot of symptoms, started by ataxia, by seizures, and then the problem from the honest of symptoms to death, it is 7 to 9 months. So that is serious disease. And when you are looking for, typically in EEG, the patient will have positive 14.33 protein, which is you can find even in brain MRI. So let's speak about diagnostic method. The diagnostic method of microorganism, we need to have a direct examination. We need to detect of antigen antibody reaction, molecular diagnostic testing, infectious process testing. So direct examination, we have stain smear for this direct examination under clinical specimen, so that they have the specimen and they can go to looking by microscope, help to determine the quality of the specimen, and then initiate a direction of antibiotic, and they need to they need to isolate. The need for isolation precaution. Of course, before that, even we need to apply the standard precaution to prevent any infection. An example of direct examination, we have a gram stain and the FB stain. I already explained for the gram stain, and the FB stain, which is already used to detect the tuberculosis. The wet mount, which is also microscopic examination for fresh clinical specimen. This one, an example for that, when you have a stool specimen, they can look on under microscope to see the ova and parasite, and vaginal swab for Trichomonas vaginalis. Also, is very important for that to see under microscope. So detection of antigen antibody reaction, antigen detection, direct method testing to present of the infectious agent through the simulation agent. As all you know, it's a very helpful tool to early diagnosis when culture are not yet positive or are not practical. So it's very important for us to see if the antigen, if there is an antigen, our body system will start to work, and the immune system, and will produce the antibody. So antibody detection is very important for us, and indirect method of identify infection by antibody production. So depend on IgM and IgG. IgM, if you have an acute infection, you will have an IgM which will be increased. If you have a chronic infection or even immune, you have IgG. Good indication for us, it means to reflect our immunity, and could be this one reported as positive or negative. Okay, this is called qualitative, and could be also reported as a titer, what called quantitative. They will have numbers. Example like RSV. Also, you have like HIV, mumps, rubella, varicella. All these things will use the same things. The molecular diagnostic testing, which is everybody speaking about PCR, polymerase chain reaction. This one you can use it to qualitative, positive and negative. Example, MRSAs, CRKB, VRE, or even for viral load. So it's very important for us. As here for the COVID, we are using the PCR for COVID swab, which is nasopharyngeal or oral pharyngeal. Test for infectious process. We have a lot of infectious process. We can see that by body fluid analysis, by CSF analysis, by C-reactive protein, by liver function test. All these things is very important for us. If we go to the body fluid, pleural fluid is very important, synovial fluid, peritoneal fluid. These things, it will give we are looking for protein and specific gravity, and even white blood cells and glucose, and that one will give an indication what type of microorganism we have it. And even C-reactive protein, also it will produce by liver, and that one it will increase in acute inflammation. So liver function test is very important, and all of you know albumin, bilirubin, and ammonia level. All these things help to diagnosis of infectious process like chronic syphilis or even certain viral infection like hepatitis B and hepatitis C. So if you focus on CBC or complete blood count, it's very important for us, especially the white blood cells count and differential. So leukocytosis, they will give you an indication there is infection or inflammation or neoplasia, and leukopenia, it could be indicate that there is viral infection. So if we have neutrophils, increase in neutrophils immediately, especially this one, if you have patient suspected meningitis, I will think about bacterial infection. If lymphocytosis, I will think about viral infection. If monocytosis, I will think about our by TB. So these things is very important and give an indication for us which microorganism caused this disease. Urine analysis is very important, just to see it in microscope, to see the color, the clarity, the protein, glucose, ketones. All these things is very important to determine the white blood cells, leukocyte, and even nitrate, most usefully to determine if the patient have urinary tract infection or not. So it's very important, even red blood cells, white and yeast, all these things will be under microscopic, and it's very important to know that things. Just to summarize my lecture, I will give the conclusion here. As I mentioned, my first slide was about the chain of infection. So the chain of infection, as I mentioned, we have infectious agent, we have reservoir, we have port of exist, we have mode of transmission, we have port of entry, and we have a new host or susceptibility host. So what our role here? Our role is just for infectious agent, we need to have a rapid identification, a rapid diagnosis, and rapid treatment to prevent or even to break the chain from the first part. Then by reservoir, we need an education. We need to focus for the people about educational, about hand hygiene, by environmental cleaning, disinfectant, sterilization. These things is very important to prevent the microorganism to reach to the people and the equipment. And then for portal of exist, we need to focus on same things in hand hygiene, control of excretions, secretions, and we need to do the aseptic technique to prevent the portal of exist, to prevent the microorganism to go to another persons. The mode of transmission, how we already stop that one or stop the chain here, break the chain by hand hygiene, by transmission-based precaution. As I mentioned, we have 3 types of mode of transmission, which is contact, and droplet, and airborne. And we need to apply the contact precaution for contact. We need to apply a droplet precaution for a droplet. We need to apply airborne precaution for airborne mode of transmission microorganism. And of course, we need to apply the standard precaution, which is it is universal for everybody, because the problem sometimes you have a patient, and then after 3-4 days you have a result, and that result they have this patient it's have a MRSA or have Acinetobacter. If I'm not taking care from the beginning, then I will have a problem. So that is very important to know from the beginning. You need to apply the standard precaution. The port of entry, same like the port of exist. We need to perform hand hygiene, and we, as all of you, we knows the hand hygiene, and my colleague will speak later on about hand hygiene, and specific there is a lecture for that, and personal hygiene and transmission-based precaution, aseptic technique, wound and catheter care, and even bundles. And these things is very important to prevent portal of entry. So the last point regarding susceptibility host, we need to organize of high risk patient. We need to treat them underlying disease and immunization. It's very important to advise everybody to take the immunization, which is effective to disease such as nowadays we know we're starting the flu vaccine campaign. We encourage everybody to take that vaccine, especially the risk group. Okay, this is last slide. Thank you.
Thank you, Hisham.
I think Ayham, are you ready?
Yes. Thank you, Hisham.
Just to save time, I think we will go to the next speaker. Next speaker is Mr. Ayham Badawi, our colleague. He is infection control coordinator. He would like to speak for us about the IBC competency using for ABIC competency model. Go ahead, Ayham. Thank you.
Okay, good morning, everybody. Can you see my presentation? Hisham? Okay.
Yes, it's clear.
Yeah, thank you. So I'll talk today about the ABIC competency model for infection control. By the end of this presentation, we are expecting from you to be able to describe the scope and burden of hospital-acquired infection, define what is competency and understand its purposes, understand the framework for developing skills and knowledge to assist IB to their specialty, understand the ABIC competency model, and we will introduce the competency model that we are using at KFC and GHA and describe the method of assessment. Let's start talking about the burden of hospital-acquired infection.
As per WHO, for every 100 hospitalized patients at any given time, there will be 7 in the developed countries, and 10 in the developing countries will acquire hospital-acquired infection. So for each 100 hospitalized patient, 7 of them in the developed country will develop hospital-acquired infection. And in the developing country, 10 of them will have hospital-acquired infection. In higher income countries, approximately 30% of patients in ICU will have at least 1 hospital-acquired infection. In the low and middle income countries, the frequency of the ICU acquired infection is at least 2 to 3-fold higher than in high income countries. Device associated infection also, it's up to 13 times higher than in the United States. As per the European Center for Disease Prevention and Control, in 2018, they estimated that more than 4 million people, they are acquiring hospital-acquired infection per year. Can you imagine that 4 million will get the hospital-acquired infection per year? And out of these 4 million, 37,000 persons will die as consequences of this infection. So really, it's a serious issue. So having a high standard of infection prevention and control, it's very essential to provide a safe environment. People are coming and admitted to the hospital to be treated, and we are surprised that they will get infection and will die, or have will have increased length of stay, will be affected negatively by this infection. So it's very essential to have high standard of infection control in order to reach of ultimate goal, which is high quality and safe patient care. To achieve this high quality and safe patient care, and to prevent the infection, we need to have competent and confident workforce that will face these infection challenges, overcome these challenges, and reduce the hospital-acquired infection. Nowadays, the infection control have received the attention of the public and the political entities, especially due to the rising in the rate of hospital infection control, hospital-acquired infection. Example, increased rate of the hospital-acquired infection of MRSA, increased number of claims of dirty hospitals. So now the role of the infection preventionist is very visible and valuable, and its value increased maybe more than 3-fold. As you know, that the infection preventionists, the practitioners who's practicing infection prevention, they came from different backgrounds. Some of them nurses, some of them have the microbiology background or biology background. So they bring very different knowledge and experience to the role of infection prevention. So the purpose of the competency is to assist in standardization of the knowledge, and also to assist the practitioner to increase their existing knowledge, understanding, and skill. Of course, all of this is to meet our ultimate goal, which is the patient safety. So what is the importance of the competencies? We have 3 importance for the competency. First of it is the competency will provide standard practice recognized by the profession, which can provide the professional expectation. Will tell the public, the people, and the employer, the hospital where the infection prevention practitioner is practicing, will tell them, this is our expectation from you. This is what we are expecting. This is the knowledge and practice and skills that we are expecting from this practitioner. The second thing is the competency will provide a framework for the practitioner himself, the new practitioner, to develop their knowledge and skills. And it's not only for the new practitioner, also for the existing one. It will help them for further development. The third one, it's about the providing fundamental or foundation for valid assessment. We need valid assessment tool to assess the improvement opportunities, the weakness point, where do we need to work more to improve ourselves as practitioners. So what is the competency as defined by the as per the Infection Control Nurse Association? The competency can be described as underlying behavior necessary to achieve a desired outcome. And a more complex definition was given by Percy. He described the competency as a complex concept that encompasses such attributes as the knowledge, skills, and attitude needed to perform a role or set of tasks to an appropriate level, grade, qualification, or achievement. While the CBIC, they define the competency as the demonstration of individual specific range of skills, knowledge, or ability. So you need to demonstrate such level of skills, knowledge, and ability to say that you are competent. Now let's talk about the EPIC competency model. This model was developed by a task force of senior EPIC leaders. They spent 2 years working with this one and been reviewed by a committee and stakeholders in the EPIC. Introduced in the American Journal of Infection Control 2012 and presented to the members of EPIC members during the 2012 EPIC annual conference in San Antonio. The nice thing, the beautiful thing about this competency model, it put the patient safety at the center. They are telling you it's all about the patient. It's all about the patient safety. We are here just to protect the patient and work to provide high quality and safe environment for the patient. In this competency, the EPIC has identified 4 critical areas, 4 domains, which is leadership, infection prevention and control, and technical domain, and performance improvement and implementation science domain. We will talk about this domain by the next slides. Leadership domain. The IB leadership is based on influence rather than authority. He needs to master the skills of collaboration, followership, program management, critical thinking, and communication. While the second domain, infection prevention and control domain, is defined by CBIC that to have the knowledge and skills for epidemiology and surveillance, risk assessment, risk reduction in infection control prevention, infection prevention, antimicrobial stewardship, use and interpretation of diagnostic tests, education, and research. For the technical domain, from its name, it's care about the technology and using the electronic medical record, the surveillance technology, information technology support, and so on. The last domain is performance improvement, implementation science domain. This one is it's about the identifying the opportunity of improvement, then assembling team, working with team, implementing the plan, and measuring the success. For example, you as a practitioner, you are identify that one of the unit has increased rate of central line associated bloodstream infection. Yeah. So there is here you can say that there is an opportunity for improvement. We need to find out where's our weakness to improve it. Is there's a problem in the dressing, for example, insertion or maintaining central line? So you identify the opportunity for improvement. Then you will call for a team. You will lead and work this team members, and you will use the quality improvement method that is suiting the, for example, root cause analysis, failure mode effect analysis, force field, or whatever you will decide to use about the quality improvement method in order to implement your plan. After implementation, you need to measure the effect of your action. Was this plan that you implemented effective or not? So you will assess, measure, you will assess, implement, and measure the effect. So this is for the last critical domain from the competency. The infection control practitioner, he need to go through stages identified by the EPIC, which is the novice, or we call the beginner, middle or proficient, or advanced expert. So he will go through these stages from novice until he will reach the expert stage. The early career or novice, this is the first stage. The practitioner will develop the skills and start preparing for and reading to pass the CIC exam. Will acquire the fundamental infection control skills. Will focus on learning how to do surveillance, reporting, the basic of epidemiology and statistics, adult education, policy development, and committee planning. They are working to understand and shape their role as a member and leading person for the patient safety in their organization. While for the professional or mid-career, this is the next stage. Now, the practitioner, they might have management or supervisory responsibility. They pass the CIC exam, and they have diverse skills and demonstrate critical thinking, which is very important. And they are start to refining their leadership skills and are effective in managing their IBC program, and they are more confident. For the advanced and expert, they are showcased in expertise in leadership, management, education. They are the expert now in data analysis, strategic planning. They promote the certification. They encourage and they help their colleague and mentor others. They are accomplished and recognized leader in their own organization and beyond. Even they start working in other and working together with other institution and organization outside their organization. This is an example. This is the 3 stages of the competency: novice, proficient, to reach the expert. For example, the novice will have the basic knowledge about epidemiology and outbreak investigation, and usually they are not leading the work for outbreak investigation. The proficient or middle, they have more advanced knowledge and experience in epidemiology and study design, and they conduct the basic cluster and epidemiological investigation, and they can collaborate with the local department. While the expert, they can design and conduct complex study investigation. They including across institutions, and collaborate with other entities like the CDC, and they can publish. They have the ability to publish the results of their work. The self-assessment to advance IP competency. As what we say, the competency, it will provide a foundation for self-assessment for development and further development of the practitioner. This is the self-assessment competency provided by the EPIC. It will contain the rating scale from 1 to 5, start from novice knowledge skills, 2 to be given to the approaching proficiency, 3 fully proficient, 4 approaching advanced, and 5 the expert or advanced. And the category, the competency category, example, the identification of disease process, and the IB practice area. For example, for this category, they will assess several practices, like ability to differentiate among colonization, infection, and contamination. Then we will choose if he is a novice, approaching, proficient, or expert. So we talk about the rating scale from the novice knowledge until the advanced and expert. So what we have here in King Abdulaziz Medical City, we will share with you our competency. We have policy established. Our goal was to develop, strengthen, and sustain competencies for infection preventionists to ensure effective work performance. As we are sharing the same aims, that we need to standardize the practice. We need to show our expectation from the infection preventionist. It will provide a framework for the new and existing infection preventionists to develop their skills, knowledge, and understanding. It will contain 6 domains. Somehow it's similar to the EPIC domains. The first one is leadership and communication, infection prevention and control, surveillance, epidemiology and investigation, and statistic, technology, education and research, quality and performance improvement, and patient safety. In our competency, there is the core component, competency, which indicate the competencies should be prerequisite common to all professionals in the field. A competency statement, it describes what has to be done, and we have a competency indicator. It will be aligned with the statement and describe what competency look like. Okay, this is a screenshot of the competency that we have. The domain, for example, management and leadership, program management and communication. The core is we're talking about the leadership. The statement is will explain to understand the role of infection prevention as a team member, facilitator or leader of multidisciplinary improvement effort. And we have the indicator and we will assess the key criteria. The method of assessment, we will give 1 for the novice, 2 for the approaching proficiency, the same like EPIC, what we explained for the EPIC, and 5 going to 5 for advanced and expert. Those the indicators. Sure, we will need to assess the knowledge, understanding of the IP through direct observation, observe their practice, oral interview, and we will do tests for the practitioners. And also, I need to introduce our study modules. Study modules for the new arriving infection preventionists. It will be based on the 6th domain, on the competency. For example, the domain 1, leadership, program management and communication. It's the same domain that we have. We'll start with the objectives, and we'll have reading materials, and at the end we will have the competency. And we are providing study materials as reference for the IBC, which is EPIC text of infection control and epidemiology, and infection prevention and control competency review guidelines, in addition to our infection control guidelines manual. It will look like this. Domain 1, leadership. We'll talk about the communication, leadership, program management. For each we have references. And we'll have post-test also. This is an example of post-test for leadership, management, and communication. So the way to validate our competency is through the passing the CIC exam. The CIC exam is designed to demonstrate the ability to apply the knowledge required to be a competent IB. So by certification, we are validating our competency. And there's an interesting thing I need to share it with you, as per one of the study published in the American Journal of Infection Control, that in the hospital whose infection prevention program are led by a director who is board certified infection prevention and control, the rate of the bloodstream infection is significantly lower than that in the hospital whose director is not board certified infection. Of course, it's related to the knowledge and the skills that demonstrated by that certified director. The association between a board certified professional and fewer MRSA infection likely reflect a greater awareness and level of implementation of evidence-based practice. So in conclusion, the EPIC views the competency as self-defined and self-assessed process. Competency is not defined by specific time, but knowledge that experience is, but acknowledge that experience is important. And in order to prepare the IBCs for current workplace demand and to help them meet the complex challenges ahead, a systematic approach presented by the EPIC in its conceptual model offer a general plan to help all IBs achieve their individual career goals while simultaneously advance the profession. And we, again, the purpose of competencies is to identify learning need of the infection control professional, serve as evaluation tools such annual performance reviews or for personal development plan, bridge the gap between variation of educational background among IB infection preventionists and standardization of practice in actual setting. Thank you very much. We'll check if we have any question. This is during partner. Okay, this is for hand hygiene. Since we need to build a patient safety section and in our hospital, where can we put it in the organization structure? It's not clear for me this question. The patient safety section, or since we need to build the patient safety section or department in our hospital, where can we put it in the organizational structure? Of course, the patient safety should be the center of all practices on the hospital. It's the ultimate goal and the center of all practices, treatment, nurses, doctor, infection control, quality improvement department. They all should focus on the patient safety. It should be the ultimate goal is the patient safety. I think this is the only question that I have. Mr. Hisham, over to you. Thank you.
Can I add to that, Ayham, if you allow me?
Yeah, sure, doctor.
So if you are talking about patient safety, the most important thing is to report directly to higher body in the system. Let's say in your organizational chart you have a director of hospital, so the patient safety should be just under the director of hospital. If you have a CEO, should be directly to the CEO. If you have it should, just close and directly report to the higher body in your system. And this is most of the organization where they have an, effective program of patient safety or even infection prevention control. They should report directly, not under department, not section under department. The department report to chairman report to whatever. No, it has to be just directly to the higher in your system. في بعض الأسئلة يا أيهم still in there. Still we have time. If you allow me, Basim, we will take some of the questions. Are you considering the years of experience to identify the level of competency? What do you think, Ayhan?
If we are following the competency model that we are having here, we said about the novice, he's preparing for the CIC exam. For the middle of proficient, he passed the CIC exam. So if I have a staff, for example, or practitioner that he is here for 5 or 6 years and he has no initiative to pass the CIC exam, or he is not developing himself, can I say that this staff who has 6-year experience will be proficient or expert, while the staff who has, for example, 4 years who passed the CIC exam, he is talented in the quality improvement in statistic, in epidemiology, who is active in working as who's expert in the outbreak investigation. I think it has to be based on the criteria that providing is not only the years of experience, because that we are believe in the specialty more than the seniority. Because if I will rely on this one, that means everybody, I will not give opportunity for the new staff to improve themselves, because the people who's 5 years or 10 years expert has older than them have the higher stage. No, for me, I believe that as per the EPIC, as per the EPIC, he has to meet this indicator criteria to see that he moved from the novice to the middle to the expert. He should show interest. He should pass the CIC exam. He should demonstrate expertise in other thing we said, epidemiology, statistic, communication, critical thinking. It's not only about the years. Yes, over to you, Dr. Master.
I agree totally. It's not only the experience. When you're talking about competencies, it means people, they should obtain what they trained with. Let's say I know how to bake cake, okay? I know how to do it. And I was baking cake for like 10 years. But when you say, am I competent? Am I, expert? I mean that I have to bring that cake and I show people that I have good pictures. People, they come to me and take from my cake, and I'm selling a lot of it, and you can taste it. And so you have to obtain it. It's not only that 10 years of experience. It's not only, it's not only, that I know how to do it. No. You have to show the excellency. You have to be competent. Competent, you mean that to obtain the thing that you trained with. You show it. You show that you're expert. You show that you are, you know how to do it and you do it right. And you have a lot of elements that as an evidence that you can do it. Program of improvement, training and qualifications, number of CME hours that you did, number of trained people that you train, a lot of things. So this is how we put competency. It's a lot of things, and this is how it's different from experience and different from qualification. You'll find somebody saying that I'm 10 years doing that, but when you come and ask him to do part of his job, which is considered to be, not even the cream of the outcome, he will not do it right. So you need to understand, and that's why we are moving from experiences. We are moving from qualifications to put people under, full 360 assessment and understand what they are doing, and let them show you that they do it right. Show you they do it right. Anyway, we another questions here. How you are recruiting? How you are recruiting the novice IBC to the IBC department? What do you think, Basim or Ayham? How are we doing that? Novice people, just started, beginner, to recruit with them?
Novice people, we have we have a process for employment and recruiting. Those people who's going to be recruited in the NGHA, they have to go through the interviews, evaluation, and test. And based on their evaluation result, we will prioritize them. Yeah. And based on our need also.
Yeah. So when you say novice, you mean that they're beginners. They have at least they have interest, and they are looking for a career path in infection prevention control. And we recruit them, but we recruit them for training. So we put them under training, and we recruit them to will be competent and at the end an expert. But you have to have a time. You have to give them, a lot of attentions to be expert at it. But we recruit them, and we train them, and we put them under continuous assessment and observation, and we give them all the right and training, and give them all hard time if they did wrong. But this is how we improve. This is how to build your career path for your people, and I think it's good that to have some novice people in your system and train them and observe them. Does your IB competency for primary health? Yeah, there is. It depends on different, like it's primary healthcare. They have infection control. They will not have surgical site infection, like bundle. They will not have CLABSI bundle, but they have their own kind of methods. Like we can do competency for primary healthcare and hand hygiene. So we have a competent people doing infection prevention control and primary healthcare setting for hand hygiene, or they can be competent in if they're running to or doing the immunization clinic or reporting public health things. So we can do that, but it depends on what services they are providing. Another questions about CIC or other diploma and master. Do you? I think you agree with me, Ayham. The CIC, we are saying CIC because it's internationally accepted.
Yes.
CIC because internationally accepted, well developed, program, and it depends on experience and also huge amount of knowledge, because they will assess every part of your knowledge in main modules or domains. But if you have diploma in your area, you have a master, all considered qualifications that it will add to your competencies. But again, competence is not only qualification, it's not only experience. Competence, it means that to show that you're competent, show it clearly, and you have evidence of how to present it. I think with that we'll move to the next. Thank you, Ayham. Thank you very much. It was excellent, talk.
Thank you, Doctor.
So we'll go to next talk with hand hygiene, Mr. Basim. Mr. Basim Abu Kazim, he's one of our dear colleague and brother. He's one of our senior infection control coordinator in our infection prevention control program here in Riyadh National Guard Hospital. So he will talk about hand hygiene, and this will be for 30 minutes. Mr. Basim, go ahead.
Yeah, thank you, Dr. Majid, for the introduction. Good morning, everyone. It's such a pleasure to be with you today. I would like to thank you all for joining us with this wonderful day, and I hope that you get the most benefit of all these sessions. I'm going to start with a historical preview, not a very historical, not all historical. I'm not going back to Semmelweis, but I will start with my session with the 2005, when the hand hygiene has issued the whole program, and then descended to the whole world in order to investigate and start the hand hygiene program. Excuse me?
The slides are not moving.
Yeah, I didn't start with the slides. It's the introduction, Doctor. It's an introduction. I didn't start with slides.
Okay.
Sorry. This is just like a preview. Okay, so since 2005, when the WHO they mentioned that they want to launch this infection control, or as a part of the infection control program, which is hand hygiene, and we consider it as a essential to avoid healthcare associated infection. Saudi Arabia was the first among those countries that signed a pledge to make hand hygiene as a cornerstone in avoiding healthcare associated infection. And since that time, of course, you know that they start to test the program in our area, and then they build it in a way that it will be like they spread the knowledge among all healthcare workers in order to give them the appropriate concept, and in order to adopt it in an appropriate way. And since that time, we have many levels of these programs. We reach many levels in education, in creating champions, and also we add it as an essential part for the link nurse program, and then recently this is our program in King Abdulaziz Medical City. What we did like kind of trainers, and then we revive the role of champions, which is already recommended from the WHO that you need to build it. And especially I'm saying this because when you are dealing with a huge institution like King Abdulaziz Medical City, and I need just to mention that King Abdulaziz Medical City was a pilot area for the hand hygiene program in all MENA, and it means Middle East and Africa. And then when we start this program, many people who came from other area, from Asia or whatever, they don't have the concept of hand hygiene, and then we really put a load of education in order to educate those population who came, and then really it was challenging for us to change the whole concept and the whole behavior. And of course, we put kind of strategy. We call it like a 5 years strategies. Every 5 years we updated. We started with something we call it ATM strategy. I'm not talking about the ATM, the one that you withdraw with money. No, we are talking about ATM. It's an abbreviation for antecedent and target, and the M is for measurement. So we're not talking about the ATM, meaning to say like the same concept as root cause analysis. So we are looking where we are, what's our target, and then after that we need to measure this target in order to exactly give an appropriate idea about the program. Anyway, so this program here in King Abdulaziz Medical City, so it has been started as effective in 2007. And then we train a lot of champions, and they are the one now who's doing auditing in the whole area. It doesn't mean that we handle this program to nursing or the champions or to the healthcare workers or any healthcare workers. What we did, we are training those healthcare workers, and then after training, we are validating our education, meaning to say, in case I pick up, for example, 2 champions from each area, we do education by the beginning of the year. After doing the education, we will just revalidate this education and the practice after 3 months to find out in case they are really following the appropriate instructions of the hand hygiene. Then after that, they will continue with their auditing. We collect the audit, we do the analysis, and then we will distribute the results to all areas. Of course, based on the areas, we put kind of a limit line, meaning to say we are looking for 70% hand hygiene compliance as an overall compliance in the hospital. Anybody who is below this level, we need to do root cause analysis. So we do epidemiological investigation. We go and check on spot exactly what's happening, why there's no compliance, and then we will reinforce the whole program by giving a awareness day, or we give like a hand hygiene day or hand hygiene activities, in order to just to promote the program and then increase the compliance rate. Now, most of you, maybe they will say that maybe they will be kind of bias. We did something called it Hawthorne Effect, and we find that most of the area that when they see you and they know you, they start to do hand hygiene without any single opportunity of doing hand hygiene, just because maybe they are intimidated, or maybe they are looking to the program in a way that they need to do it only because there's somebody who's observing them. And then we did this Hawthorne Effect for those people that the champions for, and then we compare it with the ICPs. We find that we have the same rate, meaning to say that the behavior in King Abdulaziz Medical City has been changed, and people start to perceive the concept of hand hygiene and start to do hand hygiene in an appropriate way without any thinking of there's somebody who's observing us. And this is now our target. In 2015, we put another target, 5 years, which is an ATM changing behavior. And now we are working more on the changing behavior, meaning to say when we pick up every year 2 champions from each area, and then after that we will go for another 2, and then after 2 years another 2 champions, we will reach a level that 50% or 60% of any area inside the hospital, they've been champions, they know the concept of hand hygiene, and they adopt this philosophy and does also this strategy, and then they will help you in order to reach a considerable level of hand hygiene, and then they will handle the concept to other. So this is in general what we are doing, and hopefully that will continue with the same strategy. And then recently we need just to update a new strategy. Now, what I'm going to focus on this session on the basic line of the hand hygiene audit, how we need to do it, how we need to follow the steps of the WHO, which is based on 5 moments for hand hygiene. So first of all, why observing hand hygiene practice? First of all, you need to determine the degree of compliance. I don't know my compliance in hand hygiene in the areas without performing a hand hygiene audit. You will tell me that the hand hygiene audit, maybe there's a lot of bias. We try to bring somebody as a outsources. We bring somebody and not well known in the area, and then we apply it. I think this one has been done in 2013, and we apply it in all healthcare workers. And the purpose of the study to find really the appropriate compliance of the hand hygiene among healthcare workers. And we find that, of course, there's a dramatical decreasing of compliance of hand hygiene. And we find that really there's a Hawthorne effect. People, they are only practicing hand hygiene when they find you or when they see you or they know you as an ICP or as somebody who's dedicated to do audit. And of course, we just reinforce the education again, and then in order to change that concept. And also we need to audit in order to identify the most appropriate intervention for hand hygiene. And as you know, the intervention for hand hygiene, it's based on the 5 moments. Before and after patient contact, after body fluid exposure, after leaving surroundings, and before aseptic technique. And also to report the result of observations all the time, share your results, share your analysis, and then create like kind of a teamwork or hand hygiene teamwork, including your champions, your lead nurse, and I advise you to do like a brainstorming and put all healthcare workers and make them as a part of changing in order to reach a better level. So how to observe hand hygiene? There's the most appropriate way that we find it is to go for a direct observation of hand hygiene. Direct observation meaning to say that you need to be physically in that area. And one of our experience, we are not spying on healthcare workers. We just, as soon as we reach the place, we announce that we are doing a hand hygiene audit. Now, maybe most of us, they are not agree with me with this one, but it's recommended from WHO that you need to mention that you are doing really a hand hygiene session, and you need to inform the primary nurse or the nurse in charge or the head nurses that you are there to conduct this one. And believe me, in case you are following any of these healthcare workers and you check on their performance in hand hygiene and you tell them that I'm here now just to observe your hand hygiene practice, they will be confused. And then you will get a lot of non-compliance. So this is why I believe that saying what you are doing is better than hiding. And then observing them and let them that you are observing them, they will put them on a level of challenge level between themselves. They start to think. And this is the time we know that those people, they are really, they are not following our recommendation, because we believe in case you are doing your hand hygiene, you would do it in a way spontaneously. You're not going to think about it. You can communicate by following the appropriate sequence. You will do your 5 moments for hand hygiene without even think about it. So meaning to say, of course, as a basic level, you need to be educated. You need to have a full education and full concept of the hand hygiene before starting in a practical. And then when you follow you follow it and you make it as a habit, I believe this is the time you just move to a level of thinking about doing hand hygiene onto the level that I'm going to do it without thinking and will be spontaneously. And this is the time we can say that we succeed to change behavior. And this portion or this part of healthcare workers, they are really following the appropriate recommendation of hand hygiene. And it's very important that when you are observing hand hygiene, you're not supposed to interfere with any ongoing work on the area. And even if you say something like we are recommending our staff to correct on the spot. But in order to avoid confusion or avoid conflict, and especially when you are conducting like a hand hygiene audit on the early hours in the morning while they are doing rounds, especially in ICUs, and especially when you are dealing in a hospital that they are following, it's an educational field. And they are connecting with KSAU-HS University, especially for doctors and intern and many people. They will be in this round, and they are following the consultant or whoever. So sometimes, in case the consultant didn't do the hand hygiene, it's not appropriate from me as an ICP go immediately interfere this works and ask them to do hand hygiene. We're trying to not embarrassing people. We'll give the appropriate indication in appropriate time, but it's up to you to choose which way you are going to highlight the indication of hand hygiene. So meaning to say, for me, I just go inside the rounds, I take with my hands the bottle, and I start to give hand hygiene for all people. And finally, I give the consultant who really did not follow the appropriate moments of hand hygiene. And in this way, he will start to think what I did, and without saying anything, without even put any remarks. And then I understand that by his eyes, that he really admit what he did, and then he will correct on same time. So what I'm trying to do is when you ask people to change behavior, you are not you no need to intimidate them, no need to attack them. Give your remarks in a nicely way, in case you can give it without embarrassing anybody. In case that you need to give it, just act. So I believe this is the most appropriate way, just in order to avoid conflict. Compliance should be detected according to 5 moments of hand hygiene. By experience and by the data collection, we find that most of the indicators came before and after. And very less data go for aseptic technique or before aseptic technique or after body fluid exposure. And I'm saying this because sometimes it's challenging to go, for example, for a female room to check on a healthcare workers who's dealing with a female room. So this is why we just wait outside in order to check in case he did the hand hygiene after leaving surrounding, or at least before entering the room. Sometimes, no, we need to have the permission to go and check inside, because we need to cover the whole 5 moments. So we search for the opportunity to do this. So of course, we recommend the 5 moments. Lately, we met with some ICPs who came from states, from a very well-known hospital. I can't recall it now. And then they've been sharing their experience with our hand hygiene program. So they told us that they reach a level that they are recommending healthcare workers to do hand hygiene only before and after, in order to keep your bug and keep the patient bug, keep yourself safe, and keep also the patient safe. They are focusing only on these 2: hand hygiene, before patient contact and after patient contact. In case you can do the other, it's okay. But at least when they reach this level, they find that the compliance rate is increasing, and the people, they are more compliant with the hand hygiene program. I'm not saying that I need to eliminate the other 3 moments, but it's just like a spark, an idea spark, especially with those people that they are really facing a very difficult time, in order to push people or advise people to do hand hygiene in an appropriate way. So meaning to say, give them in a opportunity after opportunity, or moments after moments, instead to give them the 5. So when people start to be really fully compliant with these 2 moments, this is the time that maybe we need to introduce the other moments that is already must be introduced, but at least with the data, we start to collect it and then check on it in an appropriate way. You need to familiarize yourself with the method and tools that you need to use. Usually, we are also, all the area, they are following the WHO recommendation and the tools with the 5 moments of hand hygiene. Of course, all of you, I believe that now they are more than aware about this virtual picture about the patient, which shows the 5 moments for hand hygiene. And then just remember that there is 3 moments for hand hygiene to protect yourself, and 2 moments to protect the patient. So after patient contact, after patient surrounding, after body fluid exposure is to protect you as healthcare workers. Before patient contact and before aseptic technique is just to protect the patient itself. And I'd go by the more details with the forms. This is the form that usually we are following. I'll go in details part by part to show you exactly what we are doing, and I'll try to move the cursor. I don't know, can you see the cursor in case I move it? So maybe it will be easier for us to check on it, hopefully. Okay, so this box, it shows you the opportunity and the indication, and also the hand hygiene action. So in general, the opportunity is the number of time hand hygiene is necessary. Okay, when you go there, and of course it will be based on the indication. But you need to know that one indication can explain one opportunity, and one opportunity can have multiple indication. Yani meaning to say, in case I have opportunity, one opportunity before patient contact, okay, I can choose one indication, one opportunity, and the action, maybe it will be hand rub or hand wash, or it depends in case it's missed. And here we add the gloves. Gloves only can be added when there is no compliance with hand hygiene, meaning to say that you've been wearing gloves and then you're supposed to leave the room. So you remove the gloves, you didn't perform hand hygiene. This is the time you need to add gloves and mist. Okay, so you don't add gloves with compliance, you only add it with mist. Okay, so as I mentioned before, one opportunity can have multiple indication, okay, up to 3 indication, and then one action, whatever it is, it's a hand rub or hand wash. But now you need to take in consideration 2 things. In case you are observing a patient that he has Clostridium difficile, and you know that C. diff, it's a spores, and in case you find that the healthcare workers, after dealing with a C. diff, going outside the room and doing hand hygiene with alcohol gel, you need to stop him immediately, because alcohol gel cannot kill spores. And this time he need to do soap and water. I'm not saying that soap and water is kill spores, but at least it will work as a glidant, or slides the spores from your hands and then make your hands safe and clear. So this is why when you are observing a patient on C. diff, you need to focus on the hand wash and hand rub. It will be as a non-compliance. Recently, we add the policy of Candida auris, and then we are facing really big challenge with Candida auris. By policy, you need to do hand wash and hand rub. So this is why it will be 2 action in case you are following healthcare workers who's taking care about Candida auris. So this is why, but we cannot put it in this way, because when they build this form has been built in 2005 based on one hand hygiene action. It cannot have hand rub and hand wash. But in general, we are focusing on hand wash with Candida auris and also in Clostridium difficile. And the purpose behind it, that alcohol gel does not kill spores and cannot kill Candida auris. So this is why you can advise your healthcare workers to follow hand wash after dealing with the spores or after dealing with Candida auris. Okay, so as I mentioned, at least you need 1 indication to define opportunity, but multiple indication may define 1 opportunity. Okay, I'll give you an example for this one. Now, in case we have 2 patients and the doctor see the first patient and he need to move to the other patient, there's an opportunity to do hand hygiene after touching the patient, and then you need to do hand hygiene before touching a patient. But in case these 2 patients are sitting to each other, no need to do it 2 times. 1 time is enough. You can consider as a 1 opportunity, but you can register as a 2 indication, which is before patient contact, okay, and after patient contact. So you can have 2 indication with 1 opportunity, and you can register it in this way. So now I need just to focus on this one. For opportunity, we have 1 opportunity, but how, as you can see, we have 3 indication. How we can have a 3 indication? Let's see, for example, the scenario as follow. You've been dealing with a patient, okay, and you have another task, which is aseptic technique task on patient B. You've been on patient A and you need to move to patient B. After moving from patient A, you did hand hygiene, okay, and then you reach patient B. No need to do hand hygiene before patient contact, because you've already done it with after patient. So at least you save your alcohol and you save your hand skin integrity. So because people now, in case you don't have this concept, they are doing hand hygiene every time they are passing from patient to another patient, and then consuming a lot of alcohols, and will affect on the integrity of the skin and can make your skin dry, and then it will be on risk or high potential risk for eczema or whatever. So this is why we are focusing on the indication. When you are dealing with a patient and you need to move to another patient, the healthcare workers, they need to understand the concept that no need to do hand hygiene in case you are going for another aseptic technique, but at condition that he's not supposed to touch any of the surrounding other than the patient. Okay, so after patient contact, you went there and then you start to prepare for your aseptic technique, and you touch the patient without even doing hand hygiene. So it can be in this way. Okay, but of course you cannot consider on the second example It cannot be two indicators in this way. The only two indicators that cannot come together is after patient and after patient surroundings. Why I'm saying this? Because in case after patient surroundings, it can be alone in case you did not touch the patient. But in case you touch the patient and you leave the room, the first action which comes first is the patient. After patient surrounding, so this is why you need to pick up either after patient in case you touch the patient and then ignore after patient surrounding, or in case you didn't touch the patient, you can go immediately after patient surrounding and ignore patients. Hopefully that it's clear. Okay, the observer points of view, opportunities, and hand hygiene action. So as I mentioned, for hand hygiene, you need to pick up one, which is hand rub or hand wash, and based on it, you need to calculate the whole compliance of hand hygiene based off the opportunity. So the opportunity, it will be the denominator, and the action that you did, it will be the numerator, and multiply by 100. I will show you on the next screen how we can do it, and this is how you can get the compliance rate of the hand hygiene. So the observer must detect at least one indication to count an opportunity. Multiple indications simultaneously occur and determine one opportunity. The hand hygiene action should correspond to a counted opportunity, and the hand hygiene action is performed either by hand rubbing or hand washing, as we mentioned. If it's not performed when indicated, it must be recorded as a missed. And also I show you exactly, I give you the example when you need to include gloves and when to not include gloves. An observed hand hygiene action not corresponding to an actual indication should not be recorded. And meaning to say, in case you didn't see, do not record. You must see the indication in order to record it. So do not anticipate that the healthcare workers, he did it. In case you didn't see it, meaning to say it's not documented. Okay, so do not anticipate. So this is how we do the compliance. You put the action, the action, hand hygiene action, whatever is hand wash or hand rub, but at least supposed to be compliance. This is what we consider as a numerator. And then you need to divide it on the denominator, which is the number of opportunities, and then you multiply by 100. And this is why how you get the compliance percentage of hand hygiene in your area. So now we go by details. As you see here on the top of each form, you have like a on the header, you have kind of information you need to fill, and it depends on each healthcare settings. For example, here the facility for us, it's King Abdulaziz Medical City. The city is Riyadh. So I need to fill this form and this form. The services, it depends, is it medical services, intensive care services, or is it surgical? The ward, we can put the ward. For the department, it can be including, or just follow your policy, or just follow your system. Each area must follow the system based on the services or department, because it's very similar. The period numbers here, sometimes you need to observe hand hygiene, for example, pre and post procedure. Period number 1, pre-procedure, or period number 2, post-procedures. So in case you want to be more specific, or you need to audit on a certain procedure, so you can pick up this period numbers. Of course, the date of your audit, starting time and finishing time. The duration of each session, we are not recommended to be more than 20 minutes. Less than 20 minutes is fine. More than 20 minutes, it's time consuming, and we recommend you to go with the rush hour. In rush hour, within 5 minutes in ICU's area, you can get a lot of opportunities. The number of opportunities, it depends. We consider it as a significant in case you can reach up to 200 opportunity per month, which is fine in case you can go with it. Otherwise, in case you want to do it as a annual analysis, or you give reports on an annual basis, it can be 150 multiplied by 4, so you can reach up to let's see 600 opportunity, which is significant to each area, and you can release a significant analysis report for hand hygiene. So now, as you find that in each forms we have columns, and then in each forms you can customize it based on your recommendation, because in case you take the hand hygiene, for example, from the WHO, it can include up to 10 or 8 opportunities with 4 columns. So usually when we are doing auditing, we are dedicating each columns to healthcare workers. So as you can see, hopefully that, let me just release it all. Yeah. As you can see, in each column, we have a professional category, and we have the code, and we have number. The professional category, meaning to say, it's a doctor, it's a nurse, it's a physiotherapy, it's a nutrition. So it depends. It depends exactly which professional you are observing, and you need to familiarize yourself about maybe a dress code. You can find that this is doctors. Maybe there's another dress code with a kind of colors. It will show you that maybe this is physiotherapy or occupational therapy. So in general, the professional, it will be according to the following to the classification in general. Nurse, medical doctors, or other healthcare workers. It depends. Each one has a specific code. So you can put, for example, nurses, you can give him code 1. For medical doctors, you can give them code 3. And then each healthcare workers must have a column in order to facilitate your calculation on the end of the sessions or audit, and then it will give you clearly how many doctors, doctor compliance, and then nursing compliance, or whoever other healthcare workers. The number here, it will depend on the number of healthcare workers that you are observing under the same category. And for example, when you are doing rounds and you find that you have 3 doctors, and then we don't advise to observe more than 3 persons, because of course you'll be lost. So just follow maximum 3 healthcare workers, and then put them under the same category, same columns, and then follow the appropriate auditing based on the 5 moments for hand hygiene. So each column will be dedicated to healthcare workers, and then each healthcare workers must be coded. And this is to facilitate the calculation and the data analysis, and be sure that the numbers, it will be related to the numbers under the same category in each area. Okay. So each row of the column corresponds to an opportunity where the indication or the 5 moments for hand hygiene and action observed are entered. Meaning to say that in case you have opportunity, I recommend you not to put many indication. Put it in this way: 1 opportunity, 1 indication, 1 action, and it will be really more easy when you need to stratify your data. Because in case you are going for opportunity and action, this is what we are looking for. Opportunity, for example, 10,000, because as a denominator, I go for the action in order to find numerator, and I can get the fully compliance of hand hygiene. For the indication, of course, there's specific calculation of the indication. So instead to count it box by box and then have many indication on the same box, maybe it will confuse you. Just keep it and dedicate 1 box to each opportunity, 1 indication, and 1 hand hygiene, and it will be really easier for the data entry to stratify the data based on whatever you recommend to do it on this column. Okay, so this image, it's very important for you, because now we have a lot of misunderstanding about the patient environment. So whatever you are seeing here in red, this is the patient environment, and then the purpose of this image, that when you are going to contact with the patient, for example, you came from outside and you need to do the first contact of patient. Of course, you need to do hand hygiene before patient contact. But let's see, in case you did your hand hygiene, and then you need to work on a patient, and after that you need to work on the pumps, or you need to touch the other push syringe, or you need to go again to the patient, or whatever. You want to go also to the patient himself, or you need to check on any other items surrounding this patient self. No need to do hand hygiene. So 1 hand hygiene is more than enough, because we consider all this surrounding as a part of the patient normal flora, or whatever the patient he is on isolation. For example, also as Acinetobacter. So we consider that this is a closed area as a part of the normal flora or whatever the patient has as organisms, extra organisms. So this is why doing hand hygiene once before patient contact and touching all this area, it's more than safe to retouch the patient again without doing hand hygiene. Okay, I believe that's all. In case you have any questions, I'm more than happy to answer you.
Basim, thank you very much. It was an excellent presentation. It just because the time, I think we are 3 minutes after time.
Okay, so
we'll
there's
take,
some questions.
Questions at the end after Yahya's presentation, huh?
Okay, so I'll be able to keep these questions here till next.
You want
till the
to
end?
check them now?
No, it's up to you, doctor. It's not big issue, but I don't want to miss the questions because there's a valuable questions here. I need to answer it. Is it possible to keep it till the end of the sessions? I will be able to refine it.
You know what? Just go ahead. It's okay.
Okay, so I'll go quick. Sorry for taking those times, but anyway, there's one question here, very important question. How are we validating the departmental hand hygiene audit? As I mentioned before, that we have a rate which is 70%. In case we are above this 70%, we consider that maybe there's a bias, and then really we need to validate. So we'll go as an ICP with the champions. We go to this area on the same time, and then we just start to check that the opportunity. We work together without sharing our audit forms to each other, and then we go for 20 minutes. Then after that, we will collect the data, and then we'll compare it between the ICP and the champions. And then whatever is near to the 70% will be adopted. So in this way, we can just avoid any mistakes or any overestimated with the rate, especially when the champions is really new, and then they put like a 90% or 100%. So this is the time just we revalidate it, and then we will put the patient under re-education, and then we will retrain them on the same videos that they've been trained before on it before start their audit. In case we have something, we call it a kappa score. This kappa score, which is 1, meaning to say it is satisfaction, and then the healthcare workers can continue doing hand hygiene. In case it's less, for example, than 60, he need to repeat his sessions and all his education session and the validation in order just to re-prepare him for a new audit. So usually this is how we validate our data, and we validate our champions education. Also, as I mentioned, they need to reassess themselves on the same videos that they've been trained on it before, and then in order to reach the approval kappa score. And this is how we consider him as a passing or not passing. For the second questions, how are we writing? Okay, I think it is a duplication with the question. Fadith, he want to ask how we'll know how many opportunities per month for the department I have to collect per hospital bed. Fadi, this is a very good questions, and I can answer you. I think I talk about it during our session. For us, 600 opportunity for 1,500 bed. 600 dedicated to each area per year is enough and can be considered as a significant data. So meaning to say you can have 150 per 3 months and work on changing behavior is more than enough. But when you need to present the data, present it based on annual, not on quarter, because quarter 150 it's not really significant. Otherwise, you need to increase it to 200, at least 200 opportunity in each area. Our target and hygiene count in each area. I think I answered this question. What's the best recommendation of hand hygiene after removing gloves? After removing gloves, hand hygiene. Of course, you need to do hand hygiene, and it depends on the organism that you are dealing with. In case it's C. diff, you need to do soap and water. In case Candida auris, you need to do both hand hygiene, soap and water, and then alcohol gel. Putting 2 indication or 3 letter confused for the person who will analyze this. Yes, this is why we recommend that you can have 1 opportunity, 1 indication, and 1 action. It will facilitate the stratification of data and will be more than enough. the last question, why it's the best recommendation of hygiene after removing gloves, I think we answered most of the questions. So in case there's another questions, I will be willing to answer you after Yahya presentation. So Dr. Majid, do you want to? I think we finish. You want to introduce Mr. Yahya, or I'll do it?
Thank you very much, Basim. I think we'll go to the next talk.
Okay, thank you very much.
Okay, thank you. So next talk, it will be the element of an outbreak investigation, will be presented by Mr. Yahya Al-Bakhit. Mr. Yahya Al-Bakhit is an infection control practitioner here with us for a long time. He's very expert and very knowledgeable, and he will share his knowledge, inshallah, with very, inshallah, beneficial talk. 30 minutes for you, Yahya.
Okay, Dr. Majid, thank you. Good morning, everybody. Today, I want to discuss with you the element of an outbreak investigation. In our presentation, we'll try to cover the definition of outbreak and all related terms. We'll describe the outbreak investigation process. Then we'll list the outbreak investigation components, and we will end with the surge capacity management plan. Definition, an outbreak or epidemic is a significant increase in the particular infection or colonization over the expected rate. As you know, for each organization, for each country, they have their own endemic rate. So if the rate is over the endemic rate, it means there is a bit outbreak or a cluster. A cluster is an unusual aggregation of health events that are grouped together in a time and place. For the cluster, we can say it's a small outbreak, not if it's small cluster, small aggregation, we call it cluster. If it's a significant increase, we call it outbreak. Outbreak, it can be for infection or colonization above usual, or if you have something unusual, even one case unusual, it will consider an outbreak. As I mentioned, it's very important to identify the outbreak. You have to have your baseline endemic rate must be available for comparison. You have to compare yourself before this outbreak, and if this is a real outbreak or not. Both cluster and outbreak require the same management. You have to do investigation management for both. Now we're going to talk about outbreak may occur for a number of reasons. The first reason, introduction of and the transmission of an infection disease within the healthcare setting, and this is what happened with us in 2015, end of 2015. During August, we had an MERS-CoV outbreak in our facility, and that time, unfortunately, we shut down our hospital because of that outbreak. And it can be because of the breaches of infection control practices. In this slide, we had a cluster of C. diff cases in oncology unit. So if you will check, we have the patient is scattered in many rooms, in room 22, in room 10, in room 23, but there is some, yes?
Sorry to interrupt, but you need to fix the slides, please.
Sorry?
Fix the slides, please.
Fix the slide?
Yes.
There's a problem with the slide?
Yes.
Okay. All of them, or the slide only?
Yes, the slide is not moving.
All of them. Okay, I will start again. Now you can see?
Yes.
Okay. I will start from the beginning. The outbreak may occur for a number of reasons. The first one, we said, if we have introduction of and transmission of infection disease within the healthcare facility, and we talk from our experience because we had an MERS-CoV outbreak in our facility in 2015 in August, and unfortunately that time we shut down our hospital. Or the outbreak can be because of the breach.
Sorry, Iham. Sorry,
Yeah,
Iham,
yeah,
for interruption. Sorry, yeah, for interruption. I believe that Hisham contacted me, and your session, it doesn't show the slides. So I think you need to go to the view.
I went there.
You need to and then repeat the same process.
It's showing
Otherwise,
is the slide showing?
please, anybody from the audience can
go to reading mode, please.
Yeah, this is the one. It's the one. It's showing now.
It's showing, but it's not in a full screen. So you need to go to view in your presentation itself. Option view, the last option.
View next to review. Yeah. No. Go back. Yes. Home. Yahya.
Yes.
Yes,
home.
here. Home. No. Insert design. The last choice. It's a view.
Okay.
Good. Yeah, view. Yes, good. Then reading view. Left. Go left.
Mm-hmm.
Left. Reading view. Next. Yes, this one.
Okay. Thank you.
Good. Okay.
Thank you. Okay, we were here. Now, the outbreak can be because of breaches of infection control practices, and this is slide because of a cluster of cases of C. diff that's done in our institution in college unit. The patient is scattered in many rooms. If you will see here, the patient is scattered in many rooms, in room 22, 23, but there is something obvious. There is a common things between all these patients. If you will see here the X-ray, it's a common source of all of these patients. Then when we investigate about this X-ray, this is a portable X-ray. That means this X-ray is related to that unit. So when we check and we investigate more, we found there is no proper cleaning and disinfection for the machine itself. We have contacted the department, and after that, we were fine. Or the outbreak can be because of the contaminated or defective product or devices. And there is, we have an experience about a cluster of cases because of the scopes. So it can be because of the contaminated, defective product and devices. And there is a study here. There was an outbreak because of the nebulizer solution. Now, to conduct the outbreak investigation, we have two major sections. The first one, the initial investigation. The other one, the follow-up, because you will investigate, then you will do follow-up to see if you are in the right way or you have to refrain your process. The primary component of the initial investigation, you have to confirm if there's a presence of outbreak. I will talk to them, I will take them one by one in the next slides. Then I have to inform the key partners. Then I have to do literature review. I have to establish a case definition. I have to develop methodology for case findings. Then I have to prepare a line listing and evidence the curve. Then I have to do the observation for the potentially implicated patient care activities. Then we'll talk about environmental sampling. Then how to implement our control measures. We'll take the first one. We have to confirm if there is really an outbreak or not. We have to verify the diagnosis. We have to ensure if the diagnosis is correct. We have to evaluate for a possible laboratory errors. Maybe this what we have now because of the laboratory error. Or we have to evaluate possible changes in surveillance and case definitions. and we have to review our clinical findings and microbiology testing results. After we're done with that, we have to confirm that if the outbreak exists or not. And we have to confirm if this outbreak is real or pseudo outbreak. What we mean if we say this is a real outbreak. A real outbreak that we have to exclude the pseudo outbreaks. The pseudo outbreak, maybe this happened because of we change the surveillance. We used to do the surveillance like twice a year. Now we become our surveillance become for the full year. Now this is a changing of surveillance. Maybe we change the test sensitivity. It can cause a pseudo outbreak. Or maybe we change the definition. If we change the definition, it can cause a pseudo outbreak. It will give you a wrong definition for the outbreak if it's real or not. So we have to make sure. Even we have to check with the lab, with the surveillance, with the denominator. All these can give you a wrong direction for the outbreak. Then we have to check a possible community associated or health associated. We have to check if this is related to community or related to our institution. If we said this is, now we verify this is an outbreak, we have to inform the key partners. We have to inform the Director of Infection Control. We have to inform the facility administration. We have to inform the public health officials and microlaboratory and other departments. Like if this outbreak happened in ICU setting, we have to inform the nurses. We have to inform the head of the ICU. If this happened in medical unit, you have to, because everyone has a role in the outbreak. Then we have to do to perform a literature review. To perform literature review, you have to go to the recent scientific literature that maybe it will guide you for a possible sources that merit for the investigation, or it will remind you for something you don't know about it. You will not start from the scratch. You will see what the other they have done, and you will continue. Now, since you did the literature review, you will go to do the initial case definition. The case definition includes the criteria for persons, place, time, and the clinical features. The place, you will typically describe the specific geographic location. Like if this happened in Riyadh, you will say in Riyadh. In ICU, you will say in ICU. The facility itself, in National Guard, you will put in National Guard. You will have to put to or describe the specific location. Person, you would describe the key characteristic of the person. If this is like a pediatric, adult, ICU patient, oncology patient. And the time, you have to mention the time when it was started. Like if we are talking about measles, like the incubation period for measles, you will go back by the incubation period to see where's the index case and how many patients are infected of that diseases. Clinical features. This is very important. Like if you are checking a pneumonia patient, you will go with a clinical feature with the sign and symptom, or you will include the X-ray with your findings. This is very important from the beginning. While you are doing the line listing, you have to include all these in your line listing. It's important to have a narrow enough definition, but it has to be a broad enough to capture the majority of cases, that you will not miss any case. Since we have the line, since we have the definition. Now we have to develop the methodology, how to find our cases. A variety of sources can be used to find the additional cases. First, if we found from the beginning we said we have an outbreak of certain diseases, and you catch that one from the laboratory result, you have to keep focus on the laboratory result to check for possible cases. If you found that you're a problem with surveillance, like you have the number of eclampsia are increasing, the number of DE are increasing, your focus will be in the surveillance, and you will check more and more in the surveillance to have more cases. Sometimes the outbreak will be related to a clinical feature of the patient with no laboratory test. So in that stage, you have to have discussion with the other healthcare worker and the clinician to have their input in that outbreak. Since we have the definition and the way how we can get our cases, we have to prepare a line listing to include all these cases together. Develop a line listing reviewing different sources of information. That include, we have to include the medical record number, patient location information like admission, discharge, transfer. We have to interview a staff to ask them about that outbreak, if there is any breaches in infection control practices, if anything newly introduced to them. We have to check all of these things. It's very important to review the potentially implicated activities. Like if our outbreak because of the Aspergillus, we will give our focus on the construction activity near to the patient care area. If we have Legionella, again, we have to go to focus on the any water related to the patient area. And it's very, very important to focus on the practice pattern and the workflow that deviated from a good infection control practices in the unit. Maybe there is no good hand hygiene practices. Maybe they are not doing with they are not following the infection control practices while cleaning, disinfecting. They are not preparing for OR in a good manner. This is many things can contribute in this one, and any deviation in infection control, it can cause to a cluster of cases or outbreak. Then you can create an epidemic curve. The epidemic curve is a statistical chart used to show or visualize the onset of disease and outbreak. It can show you that a mode of transmission, determine if there is a common cause or there is a propagated cause or the incubation period. This is one example of a point source outbreak of epidemic curve. Usually, the point source outbreak epidemic curve, it will give you the common source. And usually, this one for the outbreak that caused because of a short period of time, and all cases will fall within one incubation period. You will not have more than incubation period. All the cases will fall in one incubation period. The example for this one, for the point source outbreak, the contaminated food, or if we have an infected food handler, we'll have a source of outbreak, and those examples it will fall in point source outbreak epidemic curve. because if you will check here, we have scattered cases. We are not having all of them together, and they are in one incubation period. The other epidemic curve, they call it continuous common source epidemic. And this one, this curve, it's very famous curve. This one, if you remember, there was an outbreak of cholera in London. And that one was detected by Dr. John Snow. And Dr. John Snow found at that time the problem with cholera outbreak in London because of the Board Street pump. Here they removed the handle of the pump. After that, we don't have any cases. Actually, for the epidemic curve, it's a huge topic, and you need epidemiologists to explain all the details. Just I will give you some outbreaks, epidemic curve, and I will give you a hint about it. The last one, they call it propagated epidemic curve. This is mainly if we have from person to person a transmission, and here in this curve we have many waves of the disease. We have one wave here, and we have another wave here, and the second wave usually it's bigger than the first wave. And this epidemic curve for case of measles, and if you will see, there is it fall for more than one incubation period. Here one incubation period, here one incubation period. It means we have a progressive source. Now we will see if our outbreak needs to have environmental sampling or not. If while we are doing the investigation, we found there is something related to the environmental, we have to do environmental sampling. But before doing the environmental sampling, we have to coordinate with a microlab staff, and we're gonna tell them that we have an outbreak, and you are expected from us to send you a huge number of environmental sampling. Then we have to ensure the protocol that is in place, how to collect the environmental sampling, because there is we have to follow the correct way of collection and processing the environmental sampling. We have to ask them about the way that they want it. If they want from the surfaces, if they want it swab from air, we have to communicate with the lab to ask them about the way that we want the sampling for them. Then we have to culture only the items that are possible vector of transmission. Not usually we'll usually if we'll do environmental sampling, we'll focus on the high touch surfaces, or we're gonna depend on the bug itself. Like if we have a Pseudomonas bug, we have to focus on the liquid items. Then we have to implement the initial control measures. We have to implement varieties of infection control measures, including the transmission-based precaution. Will increase our observation. This is a very crucial part that we have to reinforce education on compliance with the general infection control prevention practices. This is very important. The education, it's playing a great role of preventing infection. So if we have an outbreak, and as we said, we have to inform the key partners that we have an outbreak in their unit. We have to educate the staff about the process of outbreak, what we are going to do, what we are expecting from them to do, and how to observe and how to implement our measures. It's very important. Then we have to develop a plan of action to ensure the compliance. We're gonna see if we have a good compliance with our action plan, or there is some area of our action plan we have to reinforce about it, or we have to modify it, because some with the initial plan, maybe some plans it will not work, so we have to modify it to achieve a good practices and a good compliance from the others. The follow-up investigation. With the follow-up investigation, initially we did a case definition. So with the follow-up investigation, maybe we have to refine our case definition if we have something happen while we are doing the outbreak investigation. But if everything remains the same, we will stick to our case definition. We'll continue our findings as usual. The follow-up investigation components, this is a continuity of what we have started with the primary investigation. We have to continue case finding, we have to continue with the surveillance, we have to review our control measures on a regular basis. If we have anything while we are doing the investigation, we need to work on it, we have to do it. Anything need to be modified, we have to modify it. And we have to consider whether an analytic study should be performed for our data. Okay, as I mentioned before, we have to inform the key holder about the outbreak. So we have to communicate with them, our partner. We have to inform them. We have to keep a good communication between all of the team that involved in the outbreak. So the communication can be in two forms. Can be a brief, or we can do debriefing on daily basis, on weekly basis, and we have to have a written report for the local health department. Usually, the written report after the end of the outbreak, and to tell them this is what happened, and this is the process, and this is what the conclusion is. Now, for every outbreak, we have contacts either from patient or from healthcare worker. So it's very important, since we have the case definition and we have our line listing. Now we have to manage the line listing. Any patient or any healthcare worker that is included in our line listing, we have to manage them. If patient, we have to communicate with their team if they need a prophylaxis or they need further management. For our healthcare worker, we have to send them to the employee health clinic for further management and assessment. And for the healthcare worker, it's very important, because some infections we need to exclude them from work. We have to exclude them from work. If they are exposed to a chickenpox, they have to be, and they are not immune, we have to exclude them from work. So it's very important with to manage the line listing and to manage the contacts and to follow up with them. Sometimes, like if I'm working in a pediatric hospital and we have exposure like for pertussis, if we have that kind of exposure to a pertussis, we are advising the exposed healthcare worker to go to the employee health clinic for prophylaxis. It's very important to verify your information and double check it, because if you didn't verify your information and it's not double checked, you will give them a wrong management. Like you will treat a patient who is not exposed because of the wrong information, or healthcare worker their name given to you by mistake. You have to verify, you have to double check your information. If it's complete, everything is in the right way, then you will move to the next step for management. Shared capacity management plan. Like if we have an outbreak in one unit, now we have to check three things. We have to check the 3S: space, staffing, and supplies. Space, like in Mayor's Cove experience, we have to check if we have an extra space for non-Mayor's Cove patient, because at that time we shut down our hospital. We considered one hospital it's for Mayor's Cove patient. We moved to a mobile hospital outside for non-Mayor's Cove patient. Space, even if you don't have a space to move the patient on, you can cohort. Like you will put one unit for the infected patient and the other unit for the clean patient. Cohorting patient together, cohorting the infected patient together, the patient who has the same infection together. This is a type of space management. You cannot do space management unless you have a good staffing, because staffing is very important to manage. Because if you extend your hospital, or you move to another hospital or another facility, you have to check the manpower that you have. Even you can check the willingness to work, because sometimes if you will force people to work, sometimes they will not work, or if they are not happy to work, they will not do their job in a right manner. So maybe you will have breaches in infection control practices or anything. So it's important to ask the staffing about their willingness to work. Supplies, it's very important. Like if we have a staffing, we have the space, and we don't have the supply, it's very, very difficult to manage. So we have to manage our supply. Because in Mayor's Cove situation, like we have to have a huge number of N95. In our institution policy, N95 is a single use. So we have to remove since it's removed, we're gonna throw it away. But during the outbreak of Mayor's Cove, we have to manage our supply. So we create like a plan to reuse the N95. At that time, we use the N95 from one single use to 12-hour shift, 12-hour shift use. But for a single healthcare worker, supplies management is very important while you are dealing with the outbreak situation. Then, to conclude, investigation of outbreak, it's in healthcare setting is a step-by-step process. It's starting from the verifying the diagnosis. It's very important to know this is a real or pseudo outbreak. This is maybe it's a wrong pseudo outbreak because of the wrong sampling, maybe wrong collection, or you are increasing the number of surveillance not used to before, or you are changing the test frequency. If you confirm that that is a real outbreak, you have to start about the process that we have said it before. Additionally, healthcare investigation often required a case findings. This is very important. As we said, you have to have a case definition. Based on the case definition, you will start to have your line listing. then you have to do your measures, because since you have your findings and you have your line listing and you have the infection control measures, you have to apply it and you have to check it from time to time to see if there is if everything in place, everything under control, or you need to refine some of the practices or modify it from time to time. And we'll not forget that we have to communicate from time to time with the stakeholders. This is the references. Thank you so much.
Shukran, Yahya. Thank you very much, Yahya, for this excellent, review for outbreak investigations. And we keep in our experience here in National Guard mentioning MERS-CoV as a major outbreak, because maybe you remember that in 2015, from June till August, we have an issue with outbreak in our hospital, which is major tertiary hospital in Riyadh, where we have good number of patient, inpatient, and also a healthcare worker infected with MERS-CoV. So this gives us a huge experience when it comes to managing, a major outbreak in a hospital, setting. But outbreak, it can be at different levels. It can be in a unit, it can be in 2 units, 3 units. It's not at a hospital. It can be major to a level of city or region. So there are a lot of grades of outbreak, and everyone, it has to be tackled in the same steps of management and thinking, which is very systematic, as my colleague Yahya mentioned. But it has to be step by step, and addressing it's the magnitude based on the problem. We have a few questions, Madria, that allow me, if you allow me, Yahya, to start, maybe you and me, answering them. So one of the questions regarding how to differentiate between the real outbreak and pseudo outbreak.
Okay. The real outbreak can be infection outbreak or colonized outbreak. I will not go to the outbreak, because I will go to the pseudo outbreak if the thing that's not from the pseudo outbreak that you are checking, it means that's real outbreak. The pseudo outbreak, maybe you have a problem with the testing. You change in the test frequency. Maybe you change in the test sensitivity. It will give you a pseudo outbreak. Like if you used to do the checking for in weekly basis for the frequency of the test. Now you used to do it on daily basis. Maybe you have increase of the number of the positive cases, and you will think this is an outbreak. But this is because of you increase the frequency of the tests. Surveillance, if you are doing, let's say, CLABSI, and I'm doing CLABSI in PICU two quarter a year, then we increase the surveillance to do it for the full year, fourth quarter years, and our number of CLABSI rate, CLABSI cases increase. This is a pseudo outbreak because we increase the frequency of our surveillance. Maybe we change the definition. The changing of definition can, especially for the non-lab outbreak, that depends on the clinical picture of the patient. If the definition change, we might have not more number of cases. Even if we change the denominator, like use, I will give you one example. There was one unit, we call it oncology hematology unit. Our denominator before, like 20 patients. We moved to a new building and we separate them to 3 units. Now each unit with 20 patients, it means our denominator now increased. Before it was 20, now becomes 60. If the rate of infection is increased, we have to evaluate it because we change our denominator. Maybe pseudonym can be a failure of specimen collection, specimen processing, maybe the result interpretation. There is a wrong with the interpretation of the result. All these can cause a pseudo outbreak. I don't know if it's clear or not.
Yeah, sure. So again, if you go over the steps, Yahya and the colleagues, the first step in outbreak investigation to verify the situation, صح? The first step to verify. So what we mean by verify, is this true or not? This is what we need to answer yourself. So my colleague Yahya, he mentioned that it could be changing in the lab, it could be contaminated in the lab, contamination at the lab side, it could be changing on the number of testing. So we need to give a rate, not number of positive cases. Different thing, different thing, including changing from test with low sensitivity to high sensitivity. So there are different things, but the most important thing, the first step in any outbreak investigation, to verify the outbreak. Is there an outbreak or not? And again, it can be one case and considered outbreak. Let's say if you have one case in your hospital of Ebola, one case of Ebola, discovered one case, you will do outbreak investigation. Though that's just one case, huh? Because it's huge impact. So the outbreak doesn't mean that you should have a different or huge number of cases. It could be one very significant, very public health concern case of emerging disease like Ebola in your hospital, la qaddar, and you consider that an outbreak and start outbreak investigation. When we have an emergence of Candida aureus, first case of Candida aureus in our hospital, now we have a lot, in our hospital all over the region. But the first case in our hospital in our region and here in Riyadh, I consider it as an outbreak because we haven't seen it before. It's something new. So I have to start an outbreak investigation. Again, the first step of outbreak investigation is to look back and verify if there is any changes in the system from testing, collections, contamination, new modality of testing, and also to go back like 3 months, 6 months before and see the trending. I'll answer one of our colleagues also questioned that we don't have, endemic rate, and I think he's trying to say that. Going back and verify in your system if you have the same trend before, which we called it self-benchmarking. Self-benchmarking. So just you go back in your system, see how many case of staph aureus, MRSA, isolated from that unit. Let's say you have a report from one of the nurses in one unit. They told you, okay, doctor, we have 2 cases now diagnosed in our unit of MRSA. Okay, you just go back, see the trend over the last maybe 3 months from that unit. How many MRSA they are recording at a time? Let's say in 1 week or in 1 month or in 1 day, and you can trend yourself and see, benchmark yourself. Our target to have a 0 emergence of any outbreak. We cannot have an endemic or basic, but this is also one of the way to verify if you have a true outbreak or pseudo outbreak. See the trending. If you have the same trend over a period of time, it means this is the usual. You have to work on it to cause it less. From impact and rate point of view, but this is not an outbreak. This is your usual trend. So self-benchmarking also is very important. The significance of the bug itself is very important to define its outbreak or not, and looking to everything around testing, new modalities, new sensitivities, new materials that with possible contaminations. All of this can also verify between true outbreak or real outbreak and pseudo outbreak. So we'll go to different maybe question. I think this is also, I mentioned it before. One of the colleagues asked how we can know if the MDRO now we have, if it's outbreak or not. If it's something like, let's say you have a ban-resistant Pseudomonas, okay, in one unit, one case of ban-resistant, Pseudomonas isolated in one unit. For me, I'll consider it an issue, and I have to investigate, and I do outbreak investigation, see the trend, verify if something that usual you see there in that unit or not, and try to connect the space and time and staff and try to see if there's any connections among them. So the significance of the case and the trending and self-benchmarking is very important. Going backwards retrospectively and see your trend of isolate, it's very important. If something sound very huge public health concern like Ebola or very bad resistant organism like Candida aureus sometimes, and we haven't seen it in your area at all, this by itself considered outbreak, and you need to investigate it. I think some of the questions just repeating themselves. I hope that I verified it already. Questions about hand hygiene, I think we'll just answer it. I don't know if Basim around or not. Regarding hand hygiene, you told that no need to do hand hygiene after touching the surround if it's for the same patient at the same flora, whereas we find many acquisition because surrounding. What's the reason? I think if you have the same patients and you touching the region, the surfaces around, and again touching the patient, this is considered part of the patient, and the flora is everywhere, so there is no need to do hand hygiene in the middle. Any comment, Yahya or Basim, if he is around?
The same thing, because anything related to the patient colonize with the patient bugs. So yeah. you will do after surrounding, if you're gonna leave the room, that the last thing you want to touch the patient surrounding. Yes, you will do hand hygiene after patient surrounding. But while you are inside the patient zone, there is no need, because everything related to the patient bugs, everything related to the patient colonize with the patient bug, unless you're gonna do cleaning procedure or aseptic task, that's some need to do and hand hygiene. But other than that, no need while you are inside the patient zone.
Yes. The same question about the endemic rate, you will not find it anyway. Nobody will accept one case of multi-drug resistance in their area. So you have to do it and benchmark yourself over time, see the trend, and see if there is any increase in the trend in the area or time. Let's say I'm comparing February of this year with February of last year, or comparing this unit with the other unit, and we trend it over time, or last 3 quarters with this quarter, last month with this month, and establish that kind of data, and you can compare and try to improve based on your trend. So if you decrease the rate and the trend in that area, it means that you're doing fine. I think that's all. We have a break and discussion supposed to be to end after 5 minutes, so I'll give you just maybe 5 minutes break for now. Thank you, Yahya. Thank you, or our colleague before. So 5 minute break, then we'll start the last session of this day with 2 presentations presented by Dr. Sultan Mazid after the break. 5 minutes break. Thank you very much all. So I would like to welcome you again. We're in the last session for today, inshallah, two presentations or two talks by our colleague Dr. Sultan Al-Maziyad. Dr. Sultan Al-Maziyad, he's working with us in infection prevention and control as a public health physician under surveillance clinic. Surveillance clinic in our setting here, they are looking after occupational health, especially things related to immunization and all communicable related for the healthcare worker in the hospital, including sharp injuries or infected fluid splashes and other things. So Dr. Sultan will present occupational health in healthcare setting. So Dr. Sultan, you're most welcome. You can start, please.
Assalamu alaikum. Thank you, Dr. Good afternoon, everyone. We'll be talking about some aspects of occupational health and healthcare settings. What I did is to combine both lectures as in one, so as to be more organized and to be systematic approach. So first, what is an occupational disease? Is any disease contracted primarily as a result of an exposure to risk factors arising from work activity. So any disease caused by work. We need to differentiate it between occupational disease and work-related disease, in case of compensation. As work-related, what we mean by work-related is someone who's having, like, for example, asthma, working in construction, so it's going to get worse. Occupational disease is caused by work. So in this lecture, the participants will be able to have an idea about the pre-employment process and immunization, to understand the concept and purpose of contact tracing and describe the systematic approach how to do it, and will have the ability to identify the best appropriate management after exposure to different infectious diseases. So what hazards do we have in workplace? We have cancers, exposure to chemotherapy, we have accidents, musculoskeletal diseases, respiratory diseases. We do have stress and infectious diseases, of course, which we'll be focusing on. So for occupational health program, it has to be evidence-based and must include a risk assessment, assessing adverse outcomes. A program has to have pre and post-exposure policies and to evaluate effectiveness of measures taken. And occupational health program in healthcare settings, we focus on healthcare personnel. The healthcare personnel we mean is all paid and unpaid persons, whether workers or volunteering, working in healthcare settings who have the potential for exposure to infectious materials, including body substances, contaminated medical equipment, contaminated surfaces, or air. So the main hazard in healthcare settings is infectious diseases. We look at the healthcare personnel as a source or susceptible host for an infectious agent. We need to consider the epidemiology of the disease, of course. What key elements we need to have if we want to establish a healthcare occupational health program. We need licensed providers, physicians, nurses. We need a good coordination with other departments. We need pre-employment and periodic screening. We need educational programs, immunization program. We need to have management and treatment, prophylaxis, and also work restriction policies. These we're gonna focus on in this lecture. Also we need to have like health counseling and confidentiality and record keeping. So we'll start with pre-employment. is a key element in any health program. It is considered as a screening tool, as secondary prevention, especially in countries that lack well-established primary care. So why are we doing it? Is to determine the capability to work. We need to protect new employees by giving the vaccine, and also to protect other personnel in the same institute if the new hires are having some infectious disease. So the components of pre-employment, we need to have medical history, physical examination, we need to do vision, hearing screening, dental screening, blood test, urinalysis, and chest x-ray. These are the things we're doing here at the National Guard Health Affairs. So what blood test we do some routine as screening for hematology, complete blood count, renal function, liver functions, cholesterol, and blood sugar, of course, as a screening and to determine the capability to work. Some specific serology testing for infectious diseases. We test for HIV, viral hepatitis, some airborne pathogens, measles, mumps, rubella, and varicella. We also do the PPD skin test or the interferon gamma release assay, the quantiferon for tuberculosis. So in case we have like abnormal blood tests, the routine ones, the blood count, the cholesterol, these will not affect or prevent employment in our institute. But we need to make sure, for example, if someone is diabetic and he's working outdoors and like EMS or something, we need to make sure that this person is having appropriate management and follow-up. Some cases we need like expert opinion, like in nephrology, we refer in case of renal failure, hematology for like really high liver enzymes. So about the serology testing, these may prevent employment, and these are mandatory in healthcare settings, like in many countries and places. So the test for HIV, what we do is the fourth generation combo test to test for the antigen antibodies. The positive result has to be confirmed with the nucleic acid testing. Will detect the virus itself. We do the PCR. So the confirmed cases are to be in a confidential way and reported to the MOH. And as for the policy for employment, depends on the viral load, treatment, and everything, whether the person is local hire or international hire. So it's a bit long process. We should get approval for the employee to work in our institute. Similar thing for hepatitis, viral hepatitis, whether it's B or C. So for hepatitis A, the serology testing for antibodies for the IgG, a positive result means the person is immune, negative result will get the vaccine, is a part of a plan, MOH and WHO, to eliminate viral hepatitis. Hepatitis B testing is, we mainly look at the surface antigen and the surface antibodies. The surface antigen will tell us if there is an infection or not. The surface antibodies will indicate immunity. So we test for these two. For someone who's having surface antigen positive, that means an infection. So we need to confirm with the PCR for the nucleic acid testing, and we check for the viral load. Similar to the HIV I mentioned earlier, we need to get approval, and depends on whether the person is local, international hire. And also this person has to be referred to hepatology, has to seek treatment for the viral hepatitis. The hepatitis C is, we have two tests for hepatitis C. The antibodies, this will indicate previous infection, but we do not know whether it's resolved or because we have like 30% of hepatitis C, they have spontaneous cure. So we need to do the hepatitis C PCR to check whether there is an active infection or not. So it's the same procedure as for hepatitis B, mostly unfit, and we check for the viral load, and depends on the job category, of course. The MMRD, measles, mumps, rubella, varicella, we check for immunity by doing the IgG test. Those non-immune, they should receive the vaccine. And TB, for TB, we have the interferon gamma release assay or TB quantiferon and the skin test. We need to have a baseline. For the skin test, we need to check whether it's like, for healthcare worker, has to be more than 10 millimeters to be considered as a positive. For immunocompromised, it's 5 millimeters. For those with no risk is 15. But we do not do it usually. What we do is the TB quantiferon is a blood test, and we have reported as positive or negative. Those with positive result, we need to follow up with chest X-ray, of course, just to rule out active TB. If normal chest X-ray, that means we're having latent TB infection. We offer prophylaxis, does not prevent employment at all. So other than the chest X-ray, we check for any symptoms. We do the X-ray, and we provide the INH prophylaxis for 9 months. Latent TB infection, INH for 9 months, some side effects for the isoniazid. We provide pyridoxine because the INH causes vitamin B6 to go down. So that's why we need to provide vitamin B6 as a supplement. It is optional. A person, a new hire, can waive it. And only active diseases is considered unfit and needs treatment and isolation as per protocol. We also test for syphilis as an STI. We check for antibodies, then to be followed by RPR and Western blot. This does not prevent employment, just the person needs to get treatment. And chest X-ray is for mainly for tuberculosis. We should check other abnormalities. Sometimes we find we have incidental findings, so a person must go and follow treatment. I remember a case of having incidental finding of lymphoma, and that was referred and followed up. So helpful, but mainly is for tuberculosis. Some additional requirements in specific situations, like in food handlers and restaurants and inside the healthcare settings, we need to do stool analysis and stool culture. And these have to be done upon hiring, on yearly basis to renew the license, the certificate, and also post-vacation. So this is for the pre-employment assessment. As for the vaccination, we need to do immediately upon hiring. Like a general overview of immunization, we have active is the use of vaccines. We do have passive, the use of immunoglobulins, already performed immunoglobulins. This is passive immunization. The active immunization, we have toxoid and we have vaccine. The vaccines, we have live and we have killed or inactivated. Inactivated, we can whole vaccine or fraction subunit. We're gonna give examples of all of these. The toxoid is modified bacterial toxin. usually does not provide like long-lasting immunity, so that's why we need multiple repeated dose. Example of which is the TD. We give it like every 10 years because it does not provide lifelong immunity. The live vaccines probably will provide, because it's similar to the natural infection. So will provide lifelong immunity, and example of these are the MMR varicella, also the BCG, the yellow fever, rota, and oral typhoid. Inactivated is killed. Examples: hepatitis A, flu. Of course, flu we have like live, we have killed, but hepatitis A is a killed vaccine. A subunit example of which is the surface antigen for hepatitis B vaccine, the polysaccharide, and we have conjugate. This is attached to protein like the PCV13. So what vaccines are indicated for healthcare workers? The first one is flu shot, of course. We all know it. It has to be given every year. It's mandatory everywhere. One point of the about the flu shot, it has to be given to everyone. Egg allergy is not contraindicated for it. The recent recommendation is even if someone is having allergic reaction to eggs, must get the vaccine even in as inpatient settings. So it's mandatory for everyone. The Tdap is given once to substitute TD, then TD for every 10 years. For pregnant healthcare workers, we need to give it like in every pregnancy, just to prevent pertussis. Because the TD and Tdap, the main difference is the pertussis part. Some precautions and contraindication is anaphylaxis and encephalopathy. The live vaccines, we have the varicella and the MMR. These are to be given subcutaneously and as 2 shots for at least 4 weeks apart, 28 days. Must be given as 2 shots. One dose is not enough, except for rubella. Rubella, 1 shot is enough to give immunity. So what we have evidence of immunity to measles, mumps, rubella, and varicella, we need either the presence of antibodies during screening, documented 2 doses of the vaccine, or only 1 for rubella, or a confirmed history of the disease. Has to be lab confirmed. Verbally is not acceptable. For measles, we also have those born before 1957, because measles, there were like epidemic during that time, so most likely the person got the infection as immune. So for the hepatitis vaccine, hepatitis A is straightforward. We give 2 shots 6 months apart. For the hepatitis B, we give it as 3 shots at 0, 0 and 6 months. We also need to check the titer, the antibodies, afterwards, 1-2 months after the 3rd dose. Has to be more than 10. If less than 10, we need to repeat the series again. Another 3 shots. So a person needs to take a total of 6 shots, and we check the anti-HBs. If above 10, that means the person is immune. If less than 10, we stop here and say this person is non-responder. He cannot get immunity from the vaccine, and that's it. We go for the meningococcal. Of course, we have like the ACWY is in one vaccine is mandatory for Hajj. It does provide immunity for 5 years. The meningococcal, the B, is mandatory for military or college students. It's not as common as the ACWY. So we do not provide it here at our institute. So this is the first part of our lecture is about pre-employment vaccination for healthcare workers. Then we go to the occupational health hazards. We have some diseases with post-exposure management. We can do something like work restriction, chemoprophylaxis, or immunoglobulin. And these are examples of which TB, bloodborne pathogens, varicella, MMR, meningitis, scabies, pertussis, and influenza. We do have some diseases with no post-exposure management. No intervention we can do. So as for assessment, first, as my colleague Yahya said, we need case definition to confirm the diagnosis, and we have an index case. So is it confirmed? If no, we stop here. If yes, we go to the next step. Was there any breach in isolation? Airborne droplet? If there is no breach, we stop. If there is a breach, then we go ask the next question. We identify the exposed personnel, and are they susceptible or not? If they are not susceptible, whether by vaccine, wearing a surgical mask, N95, we stop. If they are susceptible, we go to the next question. Does the disease have potential for further spread? If no, we just monitor the exposed and that's it. If yes, we check if any measures exist. If yes, we implement intervention post-exposure prophylaxis or management. So contact tracing is a systematic process to identify contacts, to assess contacts, and to provide the management. First, we need the person identified with possible infection. We do confirm the diagnosis. We notify the infection control department. We prepare a list of exposed healthcare workers. Then these are guided to the surveillance clinic, and we do the management part. So we're going to talk about some examples. First, we have the TB exposure. What we need to do first for those exposed to TB is to have baseline testing immediately. If positive, that means they were exposed to TB and they are having latent TB prior to this exposure. If negative, we then assess this exposure by repeating the skin test or the IGRA in 8 to 10 weeks later. If positive, we need to offer prophylaxis. For those symptomatic, we need to do chest X-ray. For those negative, twice, immediately and 10 weeks later, so they are discharged and it's fine. They did not get the infection. So this is a flow chart of tuberculosis and contact tracing. We order the TB quantiferon. If negative, we repeat it in 8 to 10 weeks. If positive, we offer prophylaxis, negative discharge. For the baseline quantiferon test, if positive, that means already is having latent TB. So we evaluate for symptoms in chest X-ray. We offer prophylaxis. If normal, we refer to treatment and as protocol and airborne isolation. If there is symptoms and chest X-ray findings suggestive of active TB. So as for the MMRV, the measles, mumps, rubella, and varicella. So of these, we have the measles and varicella. They need airborne isolation. The measles and varicella. As for mumps and rubella, they are for droplet isolation. We do have the infectivity period for measles 4 days before, 4 days after the rash. For the mumps, 2 days before and 5 days after the parotitis. Rubella 7 days before the rash and 7 days after the rash. Varicella 1-2 days before the rash until all lesions have crusted. So we have exposure criteria and we have the infectivity period. We also have the incubation period. The infectivity period is not the same as the incubation period because sometimes a person is contagious before the symptoms appear. So in these measles, mumps, rubella, varicella, first we need to check immunity status by looking at the test. Upon hiring, we look for documented 2 doses of the vaccine. If they are non-immune, there is no evidence of immunity as we mentioned earlier, so work restriction for these. The work restriction depends on the infectivity period and incubation period. For measles, it's day 5 till day 21. We may provide a vaccine for measles, has to be given within 3 days. The person still has to go through the work restriction, does not report to work. As for mumps, is during the incubation period, day 12 till day 25. The vaccine, we do not give it, does not affect the course of the infection. As for rubella, it's day 7 to day 23. Again, there is no vaccine to be given. For varicella, it's from day 8 to day 21. And we may provide the vaccine and immunoglobulin. Immunoglobulin, we provide it for pregnant ladies and also for immunocompromised. We need to give it immediately within the first few days. So this is like a graph of the work restriction for these most common infection we face at healthcare settings. The measles 5 to 21, rubella's day 7 to 23, 12 to 25, and for mumps and varicella's 8 to 21. So meningitis exposure, the incubation period we have is 1 to 10 days. Is a droplet. We offer chemoprophylaxis immediately. Either of these regimens is fine. Rifampin for 2 days, Cipro, single dose. The most common management is Cipro single dose, and that's it. But is contraindicated in pregnancy, so we provide ceftriaxone like 250 milligrams IM single dose. Pertussis we do have incubation period of 6 to 20 days. The exposure is droplet face-to-face without a mask for 10 minutes, and spending 1 hour in a room with a confirmed case. The chemoprophylaxis we immediately give after an exposure is either one of these, erythromycin, azithro, clarithrol, or TMP. The best choice depends on the situation, allergy status, but in general, azithromycin is given for only 5 days, so is a good choice. The others at least for 7 days or 2 weeks. So we go to the bloodborne pathogens, hepatitis B, hepatitis C, and HIV. If someone is having like a sharp injury or a body fluid exposure, the first step is to wash the wound and skin with soap and water. They flush the mucous membrane, for example, the eyes, irrigate with clean water. There is no need to squeeze, no use of alcohol. Then the person has to report it, then to go to the surveillance clinic. First, what we do is to assess the exposure. Is it percutaneous or mucocutaneous? Was there any non-intact skin? We assess the depth of the injury, whether there is blood in the needle, for example. These are the substances. Then we check the status of the source and the healthcare worker by testing for the surface antigen, the antibodies of hepatitis C and HIV, and we check immunity for hepatitis B. Based on what we know about the incident, we may provide prophylaxis, and we need to follow up with the employee as step 4. We need to follow up. We may do further testing. So these are general steps in every sharp injuries. Specifically, we're going to go through every one of these. The risk is highest for hepatitis B virus, 23 to 62%. Depends on the envelope antigen. Envelope does indicate active replication. The envelope antigen for the source patient. Then comes the hepatitis C is roughly 2%. HIV is the least with 0.3% of risk of transmission. So for hepatitis B serology testing, we mentioned earlier that we have the surface antigen and the surface antibodies. The anti-HBs above 10 means immunity. Less than 10 means the person is non-immune. So the post-exposure prophylaxis. We have this table. We have the employee status and the source patient status. For the employee status, if vaccinated and immune, we do nothing regardless of the source. The employee is immune, the healthcare worker is immune, the anti-HBs is more than 10. And if non-immune, so we need to give immunoglobulin. We provide passive immunity, and depends, did he receive 1 series or 2 series of the vaccine? If he received only 1, 3 shots total, so we start another series, another course of vaccine. So 1 immunoglobulin and 1 shot of the vaccine, and to follow up to 6 months with the vaccination. If the person is known non-responder, he took a total of 6 shots and there is no immunity, then we check the source patient status. If positive or unknown, we provide 2 shots of immunoglobulin 1 month apart. So this is how we approach the hepatitis exposure, hepatitis B exposure. It depends on the employee, then we look at the source. So, but hopefully, like, I mean, most healthcare workers are receiving the vaccine upon hiring, and they are immune. We had few cases who missed the vaccine or had incomplete history of vaccination or non-responder. Took 6 doses of the vaccine with no immunity, but only a few percentage of the healthcare workers. So as for hepatitis C, the post-exposure for hepatitis C, there is no prophylaxis, no treatment to be given. We do have the serology testing in the PCR. After exposure, the PCR becomes positive in 1 to 2 weeks after exposure. So it's more accurate, will detect the presence of the virus or not. In a case of a needle stick, what we need to do is to have a baseline antibodies for hepatitis C. Then we do the PCR test for the RNA 3 weeks after the exposure. If negative, that means the person did not get the infection. The issue with the anti-HCV is that it may take up to 6 months to be positive, to seroconvert, which is a lot of time just to wait 6 months to make sure. And even for the source, we do the anti-HCV, we do not do the PCR. PCR is usually more expensive. We do the anti-HCV just to assess the risk, but even if negative, maybe the source got the infection like 2 months ago, so we are not sure. But after the incident, for the employee, 3 weeks, negative result, that means there is no virus, he did not get the hepatitis C virus. And what if the healthcare worker is positive for hepatitis C after a sharp injuries? Has to be referred to hepatology for further management. Roughly 30% will recover spontaneously, but some people will need treatment for hepatitis C. So this is for the hepatology department. They will assess the need for treatment or just to wait. The third is HIV, the human immune deficiency virus. We have the test for antigen antibodies, and as a confirmatory, we do have the Western blot or the PCR. So this is how is the test can, at what timeline will become positive. I'm not sure if the cursor is clear. We have the 4th generation will detect like within 20 days. The 4th generation will become positive, let's say within a month. It's more accurate than the previous testing for antibodies. We can see the HIV virus will go up within 10 days, and we have the P24 antigen will be detected like 15 days after the infection. The antibodies will become after like 20 days and then afterwards. So here we can assess the accuracy of the test and at what time. We may need to follow up to 4 months after the exposure or the incident. If the source is known to be HIV positive, we need no delay in treatment. We provide one of the 6 classes of HIV antiretrovirals. The recommended is the same as the treatment for HIV. 3 or more drugs. We give it for 4 weeks, and we need to follow up with adverse events with the renal function and CBC. And a new thing for CDC, they have published pre-exposure prophylaxis for HIV in specific situations is the same as these classes of medications. So the recommended workup for healthcare worker exposed to HIV positive source. We need to have a baseline HIV antigen antibody for the healthcare workers. We need to do the CBC liver renal profile. We need to assess these safety profiles in 2 weeks. We repeat the HIV testing in 6 weeks and again in 4 months. This is just in case of a positive source. And that's it for post-exposure prophylaxis management for some of the common infectious diseases. We go to work restriction policies. The key point is we need we need to have these policies in hospital as to provide sick leave for healthcare workers. What factors then is the incubation period and the infectivity period, and we provide the sick leave and work restriction for the duration of the infectivity period. We also look at how the infection is the mode of transmission. It is important just to assess the work restriction if needed or not. We're going to list some of the common infectious diseases. Some of these need a work restriction, and some of them no need for work restriction. Conjunctivitis, just from contact and until the discharge ceases. The CMV, there is no restriction for it. Diarrhea until symptoms resolve, no contact and no food handling. For diphtheria, we exclude until antibodies are completed, and we do have 2 negative results, have to be 24 hours apart. Enteroviral infections, no care for infants, neonates, immunocompromised, because these are at the highest risk. For the hepatitis A, there is no contact and no food handling until 7 days after the appearance of jaundice. After 7 days, the person is not contagious, so can have like handle food or whatever the job category is in. For hepatitis B, hepatitis C, depends on national regulations. Depends how the viral load, how many units, the job categories. We have a cutoff of how many the viral load is to be allowed to have a job with invasive procedures. So these are all national regulations. The herpes simplex virus, we do have the genital, no restriction, the hands, no contact, oral, no care for high risk. HIV, again, is as per regulations, job category, the viral load on treatment, not on treatment, so it depends on specific situation. As for measles, we mentioned earlier, day 5 till day 21, or if active disease, till 4 days after the rash. Meningococcal we exclude until 24 hours after treatment. For mumps, 5 days after the onset of parotitis, if active, or to be excluded day 12 to day 25. Pertussis, for active, we exclude until 5 days after start of effective antimicrobial therapy. For post-exposure, for asymptomatic, no restriction. We do offer the azithromycin, as we mentioned earlier. For symptomatic, we exclude until 5 days after treatment. Rubella is post-exposure, no symptoms, no active, day 7 to day 23. For active, we exclude until 7 days after the rash. So these are general guidelines, can be found anywhere, CDC website. You can find the EPIC textbook. These are general guidelines available everywhere. So if you face like any of these infectious diseases, you are not sure, you just can, is well written, you can just go back to it and refer to the duration exactly, as just to make sure you're not missing anything. We continue with KBs as contact until cleared. For TB, convertant latent TB is allowed to work. You may offer prophylaxis. For active TB, must be excluded from work until non-infectious. At non-infectious, after 2 weeks of treatment, and we have 3 negative acid-fast bacilli sputum. So we need to have 3 negative results. For varicella, the chicken pox, we're not talking about the zoster, shingles, we're talking about chicken pox. Active, we exclude until all lesions dry. The post-exposure, as we said, day 8 to day 21. 28 if in case we provided immunoglobulin to a pregnant lady or immunocompromised, until day 28. Varicella virus, the chicken pox, it is airborne transmission. Unlike the shingles, which is localized, is contact. Here we go to the zoster shingles, localized contact isolation. No need for exclusion from work, but no contact till all the lesions crust. The post-exposure depends, the same as varicella, disseminated or localized. If someone who received 1 dose of varicella, there is no restriction if it's a shingles, but not in case of chicken pox. All right, chicken pox has to be 2 doses to be considered immune. We come to the upper respiratory infections, flu, some coronaviruses, common cold. We exclude from duty until afebrile for 24 hours without the use of antibiotics, acetaminophen, or of course you've heard about 3 days for the COVID-19 without symptoms, but in general the other coronaviruses is only 24 hours with no fever, can return to work. It is only for those taken care of high-risk patients, which include the pediatrics age group, the older adults, and OB department. These we need to exclude. Other than that, they should just wear the mask and report to work. So how about the COVID-19 post-exposure? This is an emerging, is evolving. The guidelines are changing based on new evidence. So, but in general, what we're doing at the National Guard Health Affairs is if we have a protected exposure, there is no restriction. We just ask the employee to go back to work and wearing a surgical mask and to monitor for 14 days. In case of unprotected exposure, which supposed not to happen a lot, because everyone should wear masks during work, the asymptomatic, there is no restriction, the symptomatic will be excluded. For how long? For unprotected exposure, they need to do the test and the swab. So based on the result, will be managed accordingly. If positive, will be treated as a positive case, and we have all the 10 days with no symptoms, 3 days after the disappearance of symptoms, or 14 days. The best approach, of course, is that we know the incubation period is up to 14 days. To make it safe, is 14 days is good enough. It depends on new evidence and specific guidelines, the need, the staff shortage in hospitals is changing between countries, between institutes. So is a new thing. There is no specific set of guidelines. I'm mentioning what we're doing at the National Guard Health Affairs, and hope I know it's a lot of information, a lot of specific dates and numbers, but of course you can always look it up, just not to miss anything. Any gap in work restriction, you're gonna make the outbreak goes larger. So this is we conclude the lectures here, and thank you for paying attention. Thanks.
دكتور ماجد.
I was talking and it was I have to repeat. Well, yeah, sorry for that. So I know it was a little bit long. Thank you, Dr. Sultan, but it's 2 lectures together, so that's why it's become long. We don't want you to remember all of what's been, discussed here. The idea of having occupational health program for your staff, it means that you have all these written as a policy, simplified and accessible to your colleagues in the hospital and those who will work in the surveillance clinic or the clinic who are looking after your healthcare worker in the hospital, and it will be like a reference. They can go and it will be updated and it's easy to look at. Very important under this occupational health, updating your employee vaccines, okay, and having a database for their basic serology and also vaccine record. So this is very important. Part of occupational health program, you have a database for your employee. And excuse me, wait a little bit, please. So this is part of the occupational health program. So you have policy and procedures, you have a database, you have a serology database for all your employee. One of the question here from one of our colleague, if you allow me, Dr. Sultan, to answer, she's saying, is it a need to give a tetanus victim after getting needle stick? So we're talking about a healthcare worker. If somebody, a healthcare worker, has a needle stick injury, and as occupational health, okay, I have a reference. I have his data when he came in. I have his vaccine record. So I go back and see if he received the the tetanus or Tdap before the tetanus vaccine alone or not. So I can understand that. I can look at it and I know if he didn't or she didn't, we'll give it. If it's been received before than 10 days, 10 years, no need to repeat it. And this is how we run, occupational health. Another, question here regarding TB, like if we have a healthcare worker who was exposed to TB, you checked his, TB skin test or quantiferant was positive, he received the treatment. This will be positive for a while, even after receiving hemoprophylaxis or the treatment for latent TB. In case if there is another exposure later on, how we can manage this patient or employee? What do you think, Dr. Sultan? Sultan?
So
Maybe
someone who got the prophylaxis will be positive, the BPD or the interferon gamma.
True.
For the exposed again, no need to do the INH again.
They have different opinions. If they exposed again, you have to wait, either to go by observation, in case if they have symptoms later on and he have the infection, or you can just look to and risk assess exposure. If it's true exposure, let's say from somebody with open TB and with positive, smear and without PPEs or we may consider retreatment. So they have different opinion. One of them they're saying no, we just observe because we cannot know if it's truly or not. Another they said you have to do risk assessment, and there are some risk assessment tools to understand the significance of TB exposure and the risk of conversion later on. But it's a difficult question. I understand it's difficult, to decide based on lab tests or BBD tests because it will be positive lifelong. Another questions about flu-like symptoms, no fever, to return to work. Staff with cough, sneezing, fatigue should not be expected to return to work. Just because there is no fever, right? How many times is this happening? And I don't know if it's a questions or a comment, but generally speaking, you have to risk assess symptoms, and if it's true, and it's not, some, we're not depending on fever, but depending on the symptoms themselves, then you have to keep the environment of the hospital safe and give sick leave for a few days and reassess after. I don't see any questions, Wallah. Here just these two questions. Is there any more questions? There is another one here regarding keeping exposed staff away from duty. Who should decide that? What do you think?
The infection control department.
Yeah. So as long you have it written in a policy and procedures, and it's a part of the infection control, policy and procedure, and they're deciding that to put somebody away because it may cause some risk to others, either patients or colleagues. They just write it, and based on the hospital policy for sick leave, it will go through it easily. So it's a responsibility of infection prevention and control, but it has to be supported by policy and procedure. I think with that we are done. Regarding measles, another question just came up now. Regarding measles restrictions for healthcare workers, it was mentioned by Dr. Sultan that exclusion will be 4 days after symptoms, but the infectious period starts 4 days prior to symptoms. Can you explain more? Sultan?
Okay, so for measles, we do have the incubation period and we do have the infectivity period. The person is infectious 4 days after the appearance of the rash, but we have the prodrome before the rash is 2 days, so that's why we go back in contact tracing. But this happened in the past, so if he's having measles the work restriction has to be for the next 4 days.
Okay, so there are two things. There is the infectious time and what they call it the other time, which is incubation period, non-infectious time.
The
صحيح.
infectivity period, and we have the incubation period.
Incubation period, yeah. And this based on studies. It's not something that we came up with. So there's internationally accepted, way of doing it. And it's mainly because it's related to the behavior of the disease in the body. There are a time where it's infectious because replication is huge and it can infect others even without the symptoms there. And there is a time where we have the disease is incubation and there is no infectious, period. There is another question here regarding COVID. How soon after exposure to a positive can one be tested? What is the window for testing, please? So what is the window for testing?
The window is the same as the incubation period, which is 2 to 14 days, but preferably as soon as possible, which is the 2 days after the exposure.
So we prefer also not to test asymptomatic people, but generally speaking, as Dr. Sultan said, after 2 days, 48 hours, till 14 days, it could be any time where patients or post-exposure, healthcare worker will be positive. So between 2 days till 14 days. Okay, with that we'll conclude. I would like to thank you all for your time, and it was very, full, of knowledge, and thank you for our colleague who shared their, experiences. We started by, leadership and infection control and stewardship program. We ended with very important topics regarding, competencies and WHO hand hygiene guidelines and elements of outbreak, and we ended with some very important points in occupational health and pre-employment and surveillance clinic in the hospital for the safety of healthcare worker. So we'll see you tomorrow, inshallah. Thank you all for being here with us and being patient with all technicality issues today, and hope tomorrow will be much smoother within Allah. Thank you very much. Thank you all. فأمان الله. شكرا دكتور سلطان.